initiating this, and I suppose that it's happening. But this is something which W4C has done it in a very interactions, both virtual and physical. It has been happening and it has come to this stage. And then we thought that I think W4C should take up this as a core activity. And this is exactly how it has unfolded. Let us start with a case history. You will be able to know which poisoning we are talking about right in the beginning. A 26-year-old woman is brought in by the family to the emergency room at 6 o'clock in the morning. 6 o'clock in the morning means obviously in the night what has happened, there was very little information. She was last seen normally in the night before p.m. So obviously 10 to 6, we do not have any information as to what happened to this lady. She was somnolent and vomiting. Past medical history is notable for a prior suicide attempt, but particulars of poisoning not known. So 8 hours ago, she was seen in a normal state. Vital signs temperature was 94.9, heart rate was 40, and blood pressure was 96 by 64 or 54. Respiratory rate was 10. You know the poison. Saturation was 86% on room air, and PaCO2 was 45. She is arousable only to loud verbal stimuli, and DCS was 10 by 50. So what is our approach at this stage? History and circumstantial evidence interpret you always with caution. You must take history as Assis laid so much of emphasis on history. But you always interpret that with a lot of caution. What you do? Stabilize airway, breathing, circulation, ABC that we have been talking about since morning. You must do. And we said that you must really treat a live patient, not a dead patient. So first you do that, and then you deal with the complications, whatever, right? So oxygen supplementation if saturation is less than 92%. And then intubate if there is evidence of airway compromise. This was 10 by 15. So you take your decision. Sometimes, even though it is said that if it is less than 8, we must intubate. Sometimes we think that there is an airway compromise and we should actually intubate it earlier. If it is required, that's your decision you can take. So if hypotension, you do fluid resuscitation and use of vasopressors. Vasopressors, obviously, it is noradrenaline and certainly not dopamine. Sometimes even we start vasopressin, right? But that is when it is a one shot. But here is not a one shot, it's actually patient is full, right? And then if there is hypertension, you can get hypertension. It's a general approach, you can get it. Use of benzodiazepine in an agitated patient. We use it. We use a lot of benzodiazepine today. Use of alpha beta blockers, labetalol also we use. If there is hypertension, you do that. Then we have incremental doses. Sometimes we also use. So again, coming back to the patient, this is 8 hours ago. She was seen in a normal state, vital signs, same hypothermia, hypotension, a little bit of desaturation. PSU2 is slightly on the high side. So what do? So how do you diagnose? You diagnose, you must do a pulse oximetry. When a patient comes to the emergency, 3 or 4 things we always do. Unconsciously, you don't have to ask. We do a pulse oximetry, we monitor these patients, we do a capillary blood glucose level, and also we do an arterial blood gas or a venous blood gas. These 4 things we always do within next 10 minutes, it must have been done. So this is what we do, and then imaging according to the clinical condition. A plain chest must be done for every patient. It must be done for every patient. Remember this because it has a lot of connotations. Because sometimes patients may have vomited out during the process in the last preceding 4 or 5 hours, may have aspirated. Patient may have some solid particles getting in. Patient may have had many things. So you must actually get a chest X-ray even if the patient is breathing normally. Plain abdominal X-ray is being done because sometimes certain radiopaque subjects patient may have taken and it will be immediately diagnosed. Right? So it should also be done along with the plain X-ray of the chest and a CT head if the patient has had an altered consciousness level. So these 3 things, it doesn't really take a lot of effort to ask for it. In fact, it is normally done in an emergency. Poisoning severity score index doesn't have any role. You may see PSS, many things are there in that, and all these scoring systems don't waste any time in trying to find out the poisoning severity score. The renal function test, the liver function test, serum electrolyte, serum osmolality, lactate of course comes in the blood gas. Ketones and co-oximetry etc. are routinely done in a case of any unknown poison. This is not something that we are asking extra. This is being done for every such case. What is toxidromic approach? Ashish has actually so elaborately talked about. It's a constellation of signs and symptoms that typically results from exposure to a particular class of toxic agents. Right? There are few classes of toxic agents. He has also very nicely covered. It will be a kind of repetition. It acts as a navigation chart to help identify the poison and send relevant investigations. So when you send a relevant investigation, you must actually explain as to why you are sending it. This is what you must do. Sometimes we ask them, why did you send this? It's a routine investigation. No, there is nothing routine. When you send an investigation, you must justify why you are sending that investigation. So this toxicology approach will also empower you to send certain investigations. See, if you have a cholinergic, and just kind of, recapitulating what Ashish has talked to us a few hours ago. And it's a diarrhea, urination, muscle fasciculations, diaphoresis, of course, bradycardia, broncholia, emesis, lacrimation, and salivation. These are cholinergic symptoms. In short, this is the acronym sludge. The sludge, if you put that, it starts from salivation, lacrimation. What is that D? D is dilatation, diarrhea, diaphoresis. Okay? Dilatation of pupil, diarrhea, and diaphoresis. What is G? G is nowhere to be found. I think G is the gastrointestinal symptoms. Okay, you have nausea, you have vomiting, all those I think comes in that. So you will remember drugs and try to expand. If it is anticholinergic, you have generally opposite. Tachycardia, hypothermia, dry skin, mydriasis, decreased bowel sounds and urinary retention, delirium and agitation. Exactly opposite of what we saw last slide. If it is adrenergic, this is also similar, like anticholinergic. This is also tachycardia, hyperthermia, dry mucous membrane. The only difference is diaphoresis. If you have, look at these symptoms. These symptoms, except diaphoresis, everything else almost there in the anticholinergic. So this is the differentiation. If it is sedative hypnotic, stuporous, comatose or comatose, bradypnea, bradycardia, hypotension, hypothermia, and meiosis. So this is something which you have to look for. Put all that, have a diagnosis, what it could be. You have bradypnea, what else could it be? It could be a sedative hypnotic, it also could be a cholinergic. Right, similarly, put that and one after the other, you strike it off and then come to one or two poisons. If it is serotonin, you have irritability, hyperreflexia, glossing, diarrhea, diaphoresis. Symptoms are more or less similar. But then you have to put that, make a differential there, and then at the end you strike it off both one by one and then come to a conclusion. So now coming back to the same patient, what is our approach? ABC, as we said, ABC has got to be our primary because we need an alive patient. We don't need a dead patient. Then of course, gastric decontamination, whether we do or not, we will know. But this is what normally we look for. Then antidotes and then other supporting therapies. Gastric decontamination, considered to increase absorption of toxin from the GI tract or to enhance elimination. Okay? So you have gastric emptying procedures, induced MSCs and gastric lavage. Should you do it? So far the information that has been given to us, we should not do it. Right? Absorption of drugs, activated charcoal, which Dr. Assis has talked about, and we will see that what it actually does. Increasing transit through the GI tract, that is cathartics. Right? So we facilitate elimination of the poison from the GI tract by giving a bowel irrigation. Right? These are liters and liters of bowel irrigation that we do. Should we do it or not? So gastric lavage, it is induced MSCs with Vivekanand. What is Vivekanand? Have you ever used it? I have not used it. I have not used it. I don't know if Assis has used it in the good old days. Vivekanand is a root available in Central America and Brazil. Right? Many people use it as an emetic. Many people still use it as an emetic. How you do gastric lavage? You have the 100 to 200 ml each time. Very frequently you go on giving it. You fill the GIT with a lot of fluid and then that will go out as loose motions. And you do it until you get what you give, so you get out at the lower end. Until then, you continue to do it. There is no good benefit, but there are undesirable side effects. when you do that, you also do a soma that often the patient who is a little comatose or a little drowsy can also aspirate. Okay? So there are more disadvantages than advantages. So we recommend against routine use of gastric lavage, which is what we did in our paper which Dr. Ashish showed. And Dr. Ashish said one thing, that he is obliged to Dr. Ray and Dr. Lunka for including him, but his contribution was stellar, nothing less than stellar, right? He is so humble that he says he thanks Dr. Lunka and Dr. Ray, but he is a terrific contributor. In fact, he is the soul of that paper. Am I right, Dr. Lunka? Absolutely. So that is Ashish's humility. This may be considered in few selected cases to present with within 1 hour, which is what we have been emphasizing since morning. But generally speaking, I have never seen, except my driver, who came with an organ phosphate poisoning. He came within 15 minutes, because my house was in my previous hospital with Dr. Runta, very, very close to the hospital. So immediately he was brought. We did that. And he became all right. We didn't have money also. Kept him till 5 o'clock, 6 o'clock. He was staying in my house campus. So therefore, I had the guts to send him home. He didn't have to pay much money out of his own pockets. So this is the only case that I have seen within an hour in my whole life. Normally you don't see, so normally you should not do gastric lavage. Unfortunately, in the emergency, when we get the call, the doctor would say, "Sir, I have put in the rice tube and gastric lavage is done." I said, "Why did you do it?" I have been saying for the last so many years, almost 50 years, but still they continue to do it. I don't know if it would really change, but unfortunately, this is what is happening. And please, for heaven's sake, unless the patient has come within an hour or so, do not do it. That is the message that we would like to give. Activated charcoal, sometimes we use it. Again, that is the same story. Maximum benefit within an hour of ingestion. And certain injections like salicylate. Salicylate, you can give it up to about 4 hours. Why? Because salicylate causes a bezoar formation, which means that salicylate again causes pyloric spasm. Like Ashish talked about pyloric spasm in the previous class. And it creates a clump. When it creates a clump, it doesn't get absorbed. So therefore, up to 3 or 4 hours, if it is salicylate, you give activated charcoal, which can actually absorb, right? Recommended dose is 1 gram per kilogram, which means if you are 60 kilos, you will have 60 grams. 60 grams is quite a bit of substance amount that you will have to give, right? Administer through another gastric tube again, and but don't give it when it is a GI pathology or it is a GI surgery. Normally, GI surgery, of course, patient has had within very few hours or few days, even. Normally, you will not find some patient to come with poison. These are the list of absorbed toxins. Everything you have in this from A to Z. And some of the toxins on the right hand side, which is in pink color, are the ones which actually do not get affected. So therefore, most of this will be put right. Aspiration is a potential complication. You must remember, if there is charcoal you are giving and you give it with liquids and there could be aspiration. Aspiration means you hide. So therefore, you have to be extremely careful in such cases. So that if you are not giving it, don't worry, because most of your patients, in fact, generally all of your patients do not have come within an hour or hour and a half of the injection. So we recommend the use of activated charcoal within an hour of poison injection. This is what we have done in our paper. Use beyond 1 hour in selected patients if there is suspected injection of sustained release formulations like pellets and sachets. Multi-dose activated charcoal or MDAC, which is administration of repeated scheduled doses of charcoal. It is shown to decrease serum levels for various agents like theophylline, dapsone, phenobarbital, carbamazepine, and quinine. What does it do? Loading dose 1 gram per kilogram followed by 0.5 grams per kilogram every 2 to 4 hours for at least 3 doses. So it comes to 60 kilos, you need 60 kilos, 60 grams, and then every 2 to 4 hours you need 30 grams. Another 30 grams, 30 grams. And that should be all. 2 possible mechanisms: interrupt enterohepatic circulation of substances selected secreted in the bile, promoting passive diffusion of poisons down a concentration gradient from the intestinal capillaries to the intraluminal gut space, a process also described as exsorption, which is what is like this. Now you have normally a poison is ingested, it goes into the capillary, on the right hand side, right? It goes into the capillary and we call it absorption, right? And then you put charcoal into the gut, and charcoal combines with the poison. And also there is some diffusion of this poison because of the concentration gradient from the blood to the intestines. So charcoal also absorbs that. Okay, we call it gut dialysis through the intestinal membrane, right? Intestinal wall. We call it gut dialysis for common man and for us also. We call it gut dialysis. If there is a short note for gut dialysis, this is it: absorption and diffusion, right? And on the left hand side, you have the enterohepatic circulation. It goes to the liver, and from the liver, it goes to the circulation. And it gets excreted in the bile, comes into the gut. That is when charcoal would help in absorbing it onto it, and then it takes it away and goes to the lower end. Okay. So this is what is absorption, and exsorption also is this, right? So this is something which we need to understand. So charcoal is beneficial, but the only problem is the drawbacks, right? So that is what, and if it is aspirated, then of course we will have it. So we recommend the use of MDAC, multi-dose, in selected drug formulations and in patients who have consumed extended or delayed release formulations. Okay, in such cases you can consider this. So don't completely throw it out of our armamentarium. It is still useful. But you have got to be very, very careful and judicious about its use. Whole bowel irrigation, WBI, which is what we talked about, cathartics, internal administration of large volumes of PEG-based solution, which is what they do for colonoscopy and all that, right? Osmotically balanced, using an NG tube, which is 1.5 to 2 liters that you have to give per hour, which is a huge thing. It can aspirate, right? Facilitates rapid expulsion of toxins through the GI tract by inducing diarrhea. Okay, target is till the rectal effluent is as clear as the influent. What you give, so it comes out. Till there, it's a huge volume. It is considered following injection of highly toxic and extended release preparations. Verapamil, lithium, metals such as iron, and asymptomatic drug factors, right? So this is something which 3 or 4 things that you can think of doing your whole bowel irrigation. We do not recommend WBI routinely. Okay, helpful in injections of sustained release or enteric coated pill formulations, injection of illicit drug packets, and also consumption of toxins and absorbed that can be not absorbed by the activated charge. Enhanced elimination, use of extracorporeal elimination techniques with hemodialysis, post-dialysis, and urinary alkalinization. Something which, of course, we do hemodialysis quite often nowadays, and it has a tremendous mortality rate. So, enhanced elimination depends on the substance's molecular weight, protein binding, and apparent volume of distribution. What is volume of distribution? If it is actually a less volume of distribution, then of course substances have a little penetration into the tissues, right? Maintains relatively high intravascular concentration. So the tissues do not actually get much if it is less volume of distribution. Should all patients receive antidotes? No question about it. It is unequivocally, it is yes. If available, antidotes are the basis of treatment of poisoning wherever it is available. But many poisons you may not get a definitive antidote, right? Its evidence is B. Why it is B? Why not A? Why not A? It can never be A. Only because do you want to embark on a multi-center studies to give antidotes to half and not to give antidotes to half? You cannot do that. So therefore, it can never be A, but it is B. B is absolutely full of evidence, right? You should take B as the best evidence in such a situation. It can never be a randomized controlled trial, right? Recommendation is strong. Other therapies, forced dialysis like cyclophosphamide, thallium, and of course isoniazid. You can do a forced dialysis, and then as quickly you can eliminate. You should do it, no matter at what stage the patient has come. Urinary acidification like amantadine, amphetamine, quinine. Amphetamine during our days, I don't know whether it is being taken by the exam going students. 70s, people used to come with a lot of amphetamine just to read, staying awake the whole night, and they would take amphetamine and they would miss the examination for sure, and they would come with this poisoning. We used to do that, right? So you can do the alkalinization of the urine. Plasmapheresis nowadays, of course, you could do, and very good results. Right? Exchange transfusion, poison induced hemolysis, dapsone particularly. Dapsone, you can do exchange transfusion and you will be able to take it out. Lipid emulsions like lipophilic drugs, we all anesthetists must have seen that in Vivekanand overdose and all that. I think this is quite good. every operating room must have lipid emulsions nowadays. Our times we used to have it and people used to look at us and say, why lipid emulsion in the theatre? But today, of course, it has become a routine. And then, of course, peritoneal dialysis we don't do nowadays. I've never seen for so many years now, almost about 25 years, we don't do peritoneal dialysis. So we do not recommend routine use of extracorporeal therapy in poisoning. And timely consideration of such focused therapies may be considered for specific indications. But having said that, I also acknowledge the fact that I think in certain centers we do dialysis, we do good, in fact, ECMO also we do. I think all these are going to come in the days to come. And I'm sure there will be standard of care once it is popularized. So coming back to this patient, 8 hours ago she was seen in a normal state, vital signs, temperature, hypothermia, hypotension, hypoxia, and arousable only to loud stimuli. This was 10/15. So do you still want to do gastric decontamination? Obviously no. Have you changed your mind? In the context of what is actually happening, like you put in a rice tube, you should not put in a rice tube, aspirate it out. So we have changed our mind. So summary of the approach, toxidromic approach is the way forward. Knowledge of the various routes of decontamination, emerging antidotal therapies, enhanced elimination techniques are actually necessary for us to understand. National guidelines, which we have got a poisoning statement, you could go through that article, which I think people, each and every member has contributed immensely to that poisoning statement. You must actually go through that. That is all that is written as of today. It stands good, hold true for our country. National guidelines and early contact with the National Poisoning Center helplines, which less said than actually done, which is why 444C has taken this initiative to become much, much more sensitive, and we would like to succeed in this for the whole nation. So remember, ABCDEA approach, airway breathing circulation decontamination, and exposure and antidote. Right? I think these are the 6 things that we need to do it in that sequence. Right? ABC is obviously the first, DEA is later. But this is the sequence that we should follow for all poisoning patients. Thank you very much.
Regarding basic and general things like decontamination.
We have already discussed about this, but still, if there are few questions, all of us will answer. There is no confusion now that must not put in must not do gastric decontamination unless you get the patient within an hour, which you normally don't do. And cathartics we don't do normally. Right? Sarcal you can consider. Right? But ideally, again, 1.5 hours within, if it is, then you can try this. Or there are patients who come with salicylates, you can try up to 3 or 4 hours, right? And otherwise, that again perhaps doesn't have much problem. Anything else that is remaining? That's it. I think these are the general approaches. Any comments or any like to take any? No? Okay.
So one thing I want to ask, the CBR guidelines, HA now is adding naloxone into BLS, basic life support. So is it justified in our country, in our setup? We are taking this, are this their opioid toxicity is so much in volume that
No, no.
Opioid toxicity is a major concern in US. Major concern. So most of their, EMS will pick up opioid toxicity patients who are unresponsive and who would have really depressed, kind of respiration. So there it is more relevant. If you ask me whether it is relevant in Punjab, yes, in the periphery it might still be relevant because there is a lot of opium, lot of heroin, and lot of overdose. But we don't have that robust EMS system where we are carrying the drugs with us in the periphery. Most of our ambulances are basically fetch and bring to the hospital, right? Even you may not have a paramedic in many of the ambulances. So wherever you have a robust EMS system, there this is advocated because they are taught ABC, airway breathing and circulation, and they are proficient in even intubating if it is needed at the site. Now, what they are recommending is that in a person where you are trying to intubate at the site of wherever you are picked up, you may or may not have adequate skills. You may end up, causing some damage. So, saying for the whenever you suspect opioid, give Narcan or naloxone so that you can prevent that intubation. We may have reached that state, but we've still not reached with EMS to that state. So BLS, if you want to teach naloxone, it's only in suspected opioid. There it is.
Where there is history forthcoming, that is.
Where there is a history,
There is an adequate used to take this.
then you can, but we don't have, how many of us have naloxone available, at the drop of the hat, it's different.
So sir, can we wait for intubation and give naloxone?
No. If you do not have naloxone with you,
No, if we have naloxone.
if you have naloxone, you have to give. That is what they are recommending, that if you have naloxone, you give it in opioid overdose patient, you can prevent a significant number of unnecessary interventions.
So that is the
That is the scenario.
If we have
That is the
naloxone
scenario.
intubation, we give that and wait. So that.
Every area can form their own guidelines. In Rajasthan now we don't see morphine poisoning or opium poisoning anymore. I have not seen other than who are addicts. And addiction is not, I would say it is rare in Rajasthan. There are some pockets. But so guidelines, we should stick to the standard guidelines that we teach and read or study. Additional, drugs, naloxone is not a cheap drug. And should not be given as such. Punjab may be a special problem.
What I want to point out is, all over India we are teaching HO guidelines.
No. You see, that is an old affair. Now we have Indian
Have
guidelines.
your Indian guidelines also?
So we should now come to Indian guidelines. There is a Resuscitation Council of India. So they have wonderful guidelines, and Dr. Chakrara has done a lot of work in this regard. So these are special situations. Western countries are suffering from addiction problem or intake.
We are also suffering in Punjab. We are suffering in Northeast we are suffering with the addiction problem, but you can't make a guideline which is valid pan-India only for one state or two states. So you need to.
There may be special problems in other areas. So we do not include all this.
Sir, my question is to Dr. Bhalla, sir. Sir, are there any standard guidelines for termination of CPR?
Yes. Yes, sir. We, standard guideline which, in the AHA guideline, I think there is a component where they write that when not to do CPR, that is number one, when not to do CPR. Second is, if any out of hospital cardiac arrest which is more than 15 minutes, unwitnessed, right? And when you have done an adequate chest compression for, 30 minutes to 45 minutes and you do not find return of spontaneous circulation, you use your advanced, agent, and you still do not find that, you can terminate, but there are instances, and one of my friends has narrated this, that this was the opioid, this was the methanol poisoning, not methanol, ethylene glycol poisoning. Ethylene glycol poisoning, and he had a cardiac arrest. And they resuscitated him. They did a CPR for nearly 1.5 hours. And then they put him on a ventilator, they brought him. He had suffered hypoxic brain damage. They did not give up. They ventilated that patient for 4.5 months. And he came out
Without brain damage?
No, he came out with a cognitive brain damage, cognitive dysfunction. But the government gave him a job commensurate with his cognitive capabilities to work. So if you have that kind of a, this was in Norway. So if you have that kind of a setup where you can ventilate a person for 4 months to 6 months, and then you have a, there you will go all up. And you, hypothermia is one condition where you should not give up. Because hypothermia till the time you have reversed or brought the temperature back to core temperature to normal, you should not stop. Poisoning is another situation where I would vouch for a slightly prolonged kind of a CPR, because you can then, try giving antidote and reverse.
Witness cardiac arrest.
See, there are definite guidelines. One maximum 2 hours. And I have resuscitated quite a few patients. One of them 2 hours, and he is now probably Lieutenant General in Army. So this was about 20 years back. In newborns, never give up dialysis until there is evidence of some life. Stop it when there is clear-cut evidence of brain death. If the patient is found to be brain dead, now if you don't have appropriate team, if one person is resuscitating, say for 30 minutes, or there are 2 persons for more than 1 hour, it doesn't serve, because it is not going to be effective CPR. So 2 hours is the maximum time.
Okay, sir.
And it will depend largely on etiologies and whether it was out of hospital cardiac arrest, in hospital cardiac arrest. In hospital cardiac arrest are worse because they are disease free. Out of cardiac arrest patients are difficult because while the patient travels from site of arrest to the hospital, then that also becomes a challenging. So 2 hours, age of the patient, etiology, site of cardiac arrest, these are, and evidence of brain death.
Okay. Say last week I have treated 5 infarctions with ventricular fibrillation. One patient, all of them survived. I gave 20 DCs, adrenaline, CPR, 20.
So it is part of 2 hours. DC is,
Almost the procedure went for 1 hour,
Yes.
but patient came out.
So I do not remember in that army officer how many DCs we had given that time.
Primary cardiac arrest, I think if it is, you can try. Particularly if the rhythm is coming and going, you must try. 1.5 hours later also the patient has walked out of the hospital without any hypoxic damage. You must try. But if it is secondary cardiac arrest, I think that you have to have at least 1.5 hours that Ashish talked about that Norwegian patient must have had a rhythm coming in, going out. Without any rhythm, you cannot continue for 1.5 hours. You will not continue for 1.5 hours. There must be a rhythm coming and going, coming and going. In that case, I think you should not give at all. How many of us have actually seen iatrogenic morphine poisoning, anesthetist particularly? 70s, there was a dictum for 3-4 years it continued that morphine and oxygen open heart surgery. Have you heard of this? I have seen this. Morphine and oxygen, 300 milligrams of morphine and oxygen alone, no air. That time, I think all these free radical injuries were not talked about. They were saying that these are all theoretical things. We have seen, you have given morphine, naloxone was not available at that stage, very, very difficult. At that stage, 400 rupees an ampule and it used to be imported. Right, 400 rupees in 70s standard, how much will it be today, I don't know. We were getting, our salary was 700 rupees, a senior resident. So therefore, that was then, and then patients will be ventilated for at least 3 to 4 days. Today, of course, we don't give morphine under anesthesia. Even in the critical care setting, we don't give morphine. So we don't see iatrogenic. And when we were actually giving a little overdose of morphine as analgesic and narcotic, then we used to give naloxone. When you used to give naloxone, how do you give naloxone? You take 400 mics into 10 cc's and then give 80 every time. When you give, patient starts breathing. I have seen a patient who has had post-anesthetic 2 respiratory rates, and each volume of tidal volume was 2 liters or 2.5 liters. So patient was still, having a little bradycardia but leaving. And then you don't have to put it at you. Give naloxone, it comes up to about 10 or 12, you leave it there. But don't throw the rest of naloxone. Naloxone, it lasts for about an hour or 2, maybe. Again it will come back. So you continue giving those 80 mics every 2 hours or 1.5 hours, and then you continue until such time it is stable respiratory. But we should not lose any patient, and not necessarily that you should intubate only patients always.
So we can have more discussions. We have panel discussions after one lecture. We can.
Just I want to excuse myself from the AHA people. So AHA itself in its questionnaire asks, you have been having a 20 minutes CPR, so what are you going to consider next? It's one of their questionnaires. So the right answer in that is start considering abandoning the CPR. So that is not an absolute thing, as rightly told by sir, but beyond 20 minutes, you can have situations where you would like to abandon CPR.
It all depends on what is the underlying comorbidity of the executive. So many things which would, a young patient, I would not give up.
Whether you are applying DMR at your institute,
DNR is there,
you can make one decision at Supreme Court.
yes, DNR is there, definitely. And the second is withdrawal of life support. We've done that.
So after this great discussion, which is very encouraging that you all are still awake and involved in the things being discussed, I'll invite Dr. Vivekanand to take us from snake to the scorpion.
I know that this is a post-prandial session. So I will take care that my talk will not be venomous. is a short talk about unknown bites, bees and stings. Unknown bite, developing signs of snake bite, scorpion sting, honeybee sting, wasp, wall lizard, rat, centipede. Lot of patients they come with by these insects. So the unknown bite, the patient will come with the history of unknown bite. Then you will have to have a navigation. So syndromic approach in the morning I discussed. So I will not go on this point, but apply a syndromic approach. You can go towards snake bite. Unknown bite is many times risky also. Wait and watch phenomena may put a patient in trouble also, but one has to admit patient at least for 24 hours. This is a scorpion sting, Mesoculus camulus is the Indian red scorpion, which is more lethal and dangerous. Which scorpion is more dangerous? The scorpion is more dangerous, the scorpion which has a big stinger. उसका स्टिंगर बड़ा है, वो ज़्यादा जहरीला है. But people they think that a big body size scorpion is dangerous. It is not like that. Stinger is big, that is the dangerous. That is the red scorpion mainly in Maharashtra. So pathophysiology of scorpion envenomation is severe scorpion envenomation blocks voltage dependent inactivation of sodium channels, resulting in intense depolarization of autonomic nerves with the massive release of catecholamines. So there are two types of signs. Effects of parasympathetic will lead to sweating, vomiting, salivation, priapism and bradycardia. Effect of sympathetic stimulation will lead to severe vasoconstriction, hypertension, tachycardia, tachypnea, pulmonary edema, hypotension and circulatory failure. So there is a stimulation of both sympathetic and parasympathetic system. So the clinical presentation, common presentation is maybe 95 to almost more than that. Severe local pain with sweating after sting bite. If patient comes with unknown bite, there is a local sweating and he is shouting, he is likely to be scorpion sting. Autonomic storm, signs are vomiting, profuse sweating all over the body, ropey salivation, bradycardia, priapism, tachycardia, fetal arrhythmias, and hypotension, hypertension, pulmonary edema, shock, MORS, and then can be death. At root level, ECG, electrolytes, very basic investigations. If possible, you can go for 2D. So the treatment is, now initially there was only drug available with the research by Bavaskar is Prazosin. Selective alpha-1 adrenergic receptor blocker. The dose is 30 milligram microgram per kg per dose 3 hourly. Why 3 hourly? Because autonomic storm is at the peak at 3 hours. Till patient becomes warm. Initially anti-scorpion venom was contraindicated. They are not contraindicated, but they were saying that it is not beneficial. But now, we are using plenty of anti-scorpion venom, and it has shown wonderful magic results. It directly neutralizes circulating venom, fast action and rapid recovery. In autonomic storm, it works very rapidly. In autonomic storm, circulating adrenaline. So circulating adrenaline works as a prophylaxis of anaphylaxis. So chances of reaction to anti-scorpion venom are very low, like anti-snake venom. Dose is 3 to 5 highest bolus. We are using 20. If local effects only, treat symptomatically. If patient has autonomic excitation, then antivenom plus processing. If pulmonary edema is there, then you will have to admit the patient and you will have to use ultimate critical care, ventilators, vasodilators. If patient has a cardiac shock, then dobutamine. And if patient has a very severe degree of envenoming multi-organ failure, then patient has to be in critical care only. You see this. This patient, 35-year male, disturbed scorpion sting, right hand infield. Sting hospital time was 45 minutes. He developed autonomic storm, cardiac shock, skin diarrhea, that is a false reading. You can see the priapism. He had a tall teeth. It's a sound, but I know. See the sweat. So this is called as skin diarrhea. This is the skin diarrhea. Okay. Dr. Pry. So this patient came out after we poured 10 vials of antiscorpion venom, dobutamine. His cardiac functions were maintained. Now what are the channelopathies? You can see tall T. That is called as Ashoka tree-like T. As recovery comes, then T becomes stented, and lastly normal T. This is a channelopathy. This that girl child had again an autonomic storm within 6 hours after antiscorpion venom. Second one, you see that the scorpion rod is red. That patient had pulmonary edema, absolutely came out. So the wonderful results, scorpion venom, antiscorpion venom is available at Pune and Hafki. This is the Dr. Bhavaskar's slide. You can see the fetal arrhythmias, hemoptysis. Dr. Bhavaskar was initially disagreed with the utility of the antiscorpion venom, but now we could observe wonderful results with antiscorpion venom. This patient, diagnosis is in front of you, was wrongly treated as a snake bite. Actually, he had priapism, sweating. This is nothing but the scorpion sting. See the focal. Local myoneurotoxicity. In our area, neurotoxicity is not seen, but outside, abroad, there is a neurotoxicity on respiratory failure also. Even hepatotoxicity is also seen, but not in India. This is a scorpion sting. Farmers they face. This is a wild honeybee sting. Commonly, there is patients are bitten by hundreds of bees. There is a pain, sweating, itching, redness of skin, severe anaphylaxis and death. I have seen only one death. The toxin is melitine and histamine. Treatment is symptomatic. Of course, the drug of choice is adrenaline, antihistamines. And careful removal of stinger. This old man and that child, girl. See the stingers we have removed. The only caution while removing stinger is don't catch a stinger with forceps. Otherwise, if you catch, it will squeeze and it will pour remaining venom. So you will have to take out the stinger in a reverse direction. You pressure in front of stinger. So hundreds of stingers we have removed. That last lady, actually she was a mother of my star, but she was a known asthmatic. She was attacked by bees, wild bees, and she was brought dead. I have seen only one death in last 39 years. So vast bite, pain, rash, and patient can be pulseless, severe anaphylaxis. PLA2 antigen, then mastoparan. These are the toxins, treatment is adrenaline, antihistaminic, steroid and symptomatic. Then common home lizards, people they come with anxiety, that is harmless. Centipede bite can cause local necrosis, cellulitis, blackening. Rat bite, generally there is a big marks, but there is no poisoning, wound can get infected. Actually, this patient is a doctor. She used to get anaphylaxis after ant bite. She was admitted 3 to 4 times with me. Ant bite, small. This is a new enemy we are seeing farmers. It is called as a butterfly larva, like a Russell Viper pattern. There can be anaphylaxis, local toxicity, cardiotoxicity, symptomatic treatment. I will show 3 to 4 other slides, which was asked by Health Ministry to me. But scorpion sting is a major issue. Internet last. So sir, Romta sir, this year NCPC asked we experts, what your patients are doing for prevention? So I will show 3 to 4. I submitted these slides to the government. Now we are taking the help of survivors. So these are the testimonials of survivors. This can be better applied in toxicology. Missionaries save this area. Each one, and mission zero mortality. This child was actually our staff is not skilled. I won't get that, but he has done CPR. May not be 100% as per the guideline. Village was drawn. 6 villages were drawn in flood. Actually, what happened at 2 a.m. child woke up with abdominal pain, vomiting, and then he was brought. He had arrest. Number two video. So this is nothing but great. Now what? Last video. So the village is totally drawn. Lot of floods were there in Maharashtra, especially in our area. I need a last video. आखिरी का ये वाला. He is a teacher. Now he is educating the people. Next one I will take. Now he has become educator. Sir, in our area, we take the services of some youngsters. We label them as Arogya Mitras. You can say venom response team. So if a patient is coming from that village, so that youngster, one who has a good nature, will inform the hospital, will be ready with ventilator, ASP, and we felicitate these fellows, and that is a VRS. They help the people in financial view. So he is a preacher. So I have said 10 preachers. What I can say is like Hindi mein pravachan ka, kirtan ka. He had a cobra bite and arrest. So I have not taken any single bite from all these 10 preachers, but I have asked them because they have a good capacity of gathering. So they go for mass awareness about snake bite in their program. So they will tell, if you are bitten by snake, go to nearby doctor. So this concept, this was presented to NCDC. So we are taking the help of so patients, severe survivors are becoming now passengers. These three fellows are from single family. One had a cobra bite, two had a viper bite. Same family, but different period. So I have printed material in Marathi. So they educate the people with their own expenses. Again, great bite. He was also served. He has a video. Just a minute. In the morning, I showed this slide, ex-MP. Till his last breath, he conducted a lot of mass awareness programs. Mr. Keshav Dhundge. Even many times in Parliament, he raised the voice. So why not to be a voice of voiceless? My cardiologist son and the doctor-in-law, we conduct a lot of CPR programs. Sir, not many patients, if CPR is done during vehicle, they can be saved. Now the concept, Himachal is implementing Bhalla sir, giving ASB in ambulance. Rather risky, but 10 miles given, that will save the life.
Yeah, we were talking to Umesh Bharti the other day.
Yeah, Umesh Bharti. So the learning more is the ultimate antidote. Sir, I would like to just discuss one quantitative matter. So my policy is at the time of discharge, we do the counseling and we present gumboot to every patient, gift. So that next time he will not come in another bite. Your good quality gumboot, even he keeps a leg. Fang of Russell Viper will not case. So that routinely we distribute and we will do the counseling of the family together, do's and don'ts. All this you can see the gumboot distributions. Your NGOs are coming ahead. That's why, sir, in last 2 years we could achieve zero mortality. Of course, that is limited to my 5 to 6 talukas. So awareness, basic life support, C for counseling, C for corrective measure. I always say ICU means first intensive counseling unit and then intensive care unit. ICU stands for intensive counseling unit first. Then D for development, poison centers, in Maharashtra 3 ICMR centers. So one concept I like from Tamil Nadu, poison centers in patients, they connect the patients every 3 months, those patients who attempted suicide. One psychiatrist comes, they come to the center, their counseling is repeatedly done and they are given advices about the positive thinking towards life. E is education. We have in APSE, we have requested to update the syllabus. Sir, Rukta sir, you be all from the toxicology. So my humble request is, why not update syllabus with special chapters on toxicology? Of course, there are chapters on toxicology, but there are no chapters on toxicology. And here for first aid. So this is the end of this small presentation. So you can use your patients, those who are saved by, they are very, very best messengers and they will teach in a better way than us also. So we have implemented this policy, that's why we could achieve this zero mortality. So testimonials of survivors, help of survivors, and then Arogya Mitras and Venom response team. Such kinds of things. Dr. Ashutosh was telling me that he has a 2,000 bedded hospital, he has treated 300 beds. But if you have a medical college, ESF department is there, such activities can be implemented at your center. Thank you, sir. Thanks to everybody again.
to Dr. Vincent, and we'll be discussing about pitfalls in early toxicology management. So we have discussed the management with different angles. So now, what further we can have to discuss it?
Good afternoon, everybody. And at the outset, I'd like to thank W4C for inviting me here. And now we'll be discussing the pitfalls in the early toxicology management. And my esteemed panelists are all the stalwarts in the field of toxicology. Dr. Gupta sir, Dr. Khanna sir, Dr. Munde sir, Dr. Tejas, and Dr. Vivekanand. So medical toxicology is one of the most important and dynamic fields of medicine today. And all of us who are sitting here must have seen a patient of poisoning in our life. Accidental, incidental, over-the-counter drugs, and India being an agricultural country, a lot of insect bites. So we know that poisoning is, the load of poisoning is very high, is the fourth common cause of mortality. And the suicide rate in India is double the suicide rate all over the world, annual rate. And ingestion accounts for about 1/4 of those poisonings. And pesticide poisoning is highly prevalent in India, the most common cause of suicides. WHO has estimated that snake envenomation is about 1 lakh, and about 3 times the number of these patients have morbidity due to amputation and incomplete recovery. You can take your chairs.
So that people can see the screen.
That is also,
So WHO has recognized snake bite is one of the neglected tropical diseases, and it has a target to halve the number of deaths of snake bite all over India, and we are very impressed by these efforts that is putting. And about 1 lakh patients, half of the deaths due to snake bites have been reported in India. So we know that diagnosis of poisoning is very important, and many of times we have an asymptomatic patient who comes with a positive history of poisoning. On the other hand, a typical patient with a toxidromic approach, but there is no positive history. So, sir, how do you handle these navigating challenges in history taking in an acute case of poisoning? Start from Dr. Gupta, sir. So
Thank you, Dr. Gunchan. I think the two lectures, one taken by Dr. Ashish Balla and another by Dr. Ray, approach to a patient with unknown poisoning, were quite self-explanatory that when we have asymptomatic patient and with positive history of any poison consumption, and he fits into toxidrome.
So sometimes there is asymptomatic, but there is a history that he's consumed the
Right.
On the other hand, so how
You have to go through the exercise which was described, approach to a patient with unknown poisoning. If he needs resuscitation, if there is an evidence, is he fitting into any toxidrome? Is he, 4 poisons are commonest in India. One is aluminium phosphide, another is organophosphorus. They constitute almost anywhere between 40 to 50% of all poisoning patients. Third is snake bite, another 20 to 25% depending upon areas. And then we have corrosive poisons, which has about, say, 10 to 15% again, depending upon epidemiology. The rest of the poisons are left to rest of the 10%. But these 10% may be rising in number because of development or what we call as consumption of more drugs, drug dependency, addictions, and there are geographical areas. Now Punjab is suffering, Northeast is suffering, part of Maharashtra, bigger metropolitan cities. So you have to make sure what is needed and you have to be very clear in your approach to these patients. Don't act in haste. Don't just go through the approach which is classically described in literature, what you have heard, and administer or do an intervention only if it is needed. Mostly it is diagnostic approach, and if you think the patient needs some intervention, assistance, chemotherapeutic drug management, go ahead with that. That will be my approach.
Excellently said. History in poisoning cases is always taken with a pinch of salt. Even if a patient who has self-consumed poisoning, the history might not be very reliable. So, and the information has to be seen sometimes from the peers, the family members about discordant relationship, any event that has happened in the past. There is an exam and the patient has not fared well. So, such incidental findings are very important. On the other hand, toxidromic approach, no doubt, has been very helpful. It is the navigation chart for the clinician. But nowadays, because of polypharmacy, co-ingestion, adulteration, I'd like to highlight an incident that we had a patient who presented in delirium, admitted with psychiatry and then with neurology. So after the delirium settled, we could see that there are blue buttons lying on his gums. He was a case of lead poisoning. So how did we came to know he was taking Kamini tablets. Now this Kamini is an Ayurvedic medicine available online. But it does not have lead. It has opium, the maximum, 12 parts of opium. And that opium has been adulterated with lead, he has been chronically taken. So adulteration is also that deviates your patients from this, actually the clear history taking. And presentation of the patient depends on many factors, the amount the patient has ingested, the route of taking, the accidental or intentional, or what is the accidental, acute or chronic poisoning. So sometimes these things help us. The subject behavioral changes, the history of an opioid, the history of access to the medications, like the pills are available at home, the patient is an opioid addict, or children who have consumed their elderly's antihypertensive of this. So empty packets, circumstantial evidence helps in history taking. There are incidences when an addict takes a poison because he is been to a de-addiction center, he's lost his tolerance, and he comes back and takes the same dose, he's now intoxicated. So history taking is very challenging in these patients of poisoning. So suspect when you cannot explain the symptoms, and history is the most important tool in medicine, but not in poisoning. You cannot completely rely on history. So if we can't rely on history, so sometimes we feel we set the tox screen, it will give us the answer. So what are the pitfalls of over-reliance on drug screening tests in acute poisoning? Bala sir?
Yeah, before I go on to this, can we go back to the last slide? Yeah. History of access to medicine. What is the most common prescribed medicine in India? Most common prescribed medicine?
Antihypertensives.
Antihypertensives, beta blockers, ATT. Has any one of us seen an intentional anti-tubercular, drug overdose? Nobody will take. I haven't yet seen even a single case of INH. We've seen Dapsone patient developing IV hemolysis because they are G6PD deficient. That's a different thing. But we haven't seen overdose with these. We have now started seeing calcium channel blockers and beta blockers, but we have never seen a patient overdosing on aspirin, overdosing on statins. What we commonly see is, because these drugs are taken by patients to save themselves. The illnesses which cannot be controlled, epilepsy. So you have people overdosing on anti-epileptic drugs. So those are the drugs which are common. Patient overdosing on lithium, patient overdosing on prescription antipsychotic drugs, barbiturates. So these are the drugs which people commonly take. Not the beta blockers, aspirin, rosuvastatin or atorvastatin, or calcium channel blockers, or INH, or rifampicin, or ethambutol. They don't overdose on these drugs. So this is also important thing to know. Antihistaminics, an important drug. People who are having skin disorders which are not responding. Eczema. Methotrexate we see when people who are having rheumatoid arthritis, they are having ongoing pain and they are not getting relief. So they take inadvertent overdose. So these are the situations which you should remember. What she's pointed out is complementary and alternative medication. I won't use the name for obvious reasons, but complementary and alternative medication.
But then ease of availability.
Containing heavy metals and other herbs which can cause problems. The reason why people overdose on them is because they think these are harmless. These are harmless. That is very important. Now coming to what are the investigations which we should do. Now the urine screening, toxicology screening is again very variable kind of a test. You have various kits available which can detect 2, 4, 6, 10 or 12 samples, 12 drugs, and they have agents which, and we have agents which can be detected between 12 to 24 hours for up to 24 hours. But then we have some metabolites which are detected even up to 4 to 6 weeks. So some of these tests are reliable, some of them are not reliable, and then there is a cross reactivity. Although you should collect an acute urine sample in a poisoning where you are suspecting a recreational drug overdose or an unknown poisoning, you can collect the first urine sample when the patient has come in. But you may get a true multi-drugs positivity, or you may get some drug positivity and some false positivity. So there it becomes very difficult to interpret those results. Any urine tox screen result has to be interpreted in context of clinical findings. Now you may find a benzodiazepine positive, but the patient doesn't appear like a sedative hypnotic overdose. So that benzodiazepine may have been given to him at an outside hospital or by someone which is now showing in the urine. So those are the things which you should keep in mind. And then there are certain drugs which are not fixed up in urine tox screen. And one of them is dextromethorphan is not picked up. Then you have propoxyphene is not picked up. So all those drugs which people use and which cannot be picked up, you should also be careful about. But collecting a urine and a blood sample and sending it for analysis is very, very important. You may collect a gastric lavage sample, but you may not get anything out of it. So many times people collect a gastric lavage for aluminium phosphide. Now tell me, what you are interested in knowing is phosphine. You are not collecting the gas sample. You are collecting a gastric lavage. So all you will detect is aluminium hydroxide. You will never detect aluminium phosphide. But it is being reported as aluminium phosphide detected. I don't know how. So these are the problems with the interpretation of the test.
I just want to add few things into this, because many times what will happen that we are sending the urine or the blood reports for the laboratories for the tox screen or something, even though that we know that the person may have ingested this alprazolam or benzodiazepine overdose. So what I would like to tell that only the SAN dose investigations which will help you in management.
Yes.
Because if you know that the person may have benzodiazepines positive or negative, does it make any difference in the treatment? Because many times what will happen that patients may have a financial crisis and we are sending 3,000, 5,000 rupees of screening text. So I believe into this practices point of view that just send those samples which will help in your management perspective. Suppose the person have taken paracetamol overdose, definitely I would like to see the paracetamol label because I want to give an assistant for this management of the paracetamol overdose. So that is very important, and important thing that you have to be open your all the sites and you have to understand that person have taken this kind of medicines or the drugs or the chemical exposures. Then unusual presentation, then you have to think accordingly and you have to done the test which will be helping you management.
More about the time lag. Even if they come positive, they return by the time the acute crisis has been managed. So the time lag, and there is a list of people, as Sir rightly pointed out, list of medicines which are not detected by this. So, and the initial urine sample may be done too fast. So these are the type of samples, and sometimes you need to be well versed with this because the absence of the line shows that it is positive. And you can see many of these drugs like barbiturates, codeine and metaplex. Many of these drugs are positive till days after. And then it is questionable performance in the presence of frank hematuria, myoglobinuria and casts. And as Sir points out, that like for benzodiazepines only this is olanzapine is checked. So if this is a party drug which is flunitrazepine, it is not in the checklist. So it will come negative even if the patient has been poisoned. The patient may be a chronic opioid user, it will be positive. So the positive test does not confirm and the negative does not rule out toxicity in these patients. So what is the medical legal point of view? You should do this or not? What is their stand?
You know, I just wanted both of them talked, I think, almost antagonistically about the toxicology screen and the blood testing. I have never been benefited with the blood or urine testing. For one, it comes after 3 or 4 days. By then, already it is settled. Patient has become alright more often than not. And the second thing is that often we have seen the urine tox screen says that it is cannabis. You send 10 samples, you will get 6 samples at least, it is cannabis. Cannabis doesn't require anything to be actually done. It automatically gets clear. And by then the report comes, by then it is already clear. Cannabis, certainly many people in the villages particularly take it. You know, Chilam में take पड़ता है. अपना meeting में, Brazil में, बस करते जाता है. They share that Chilam with everybody. And they must be having that. I can assure you that. But it doesn't again cause any death. It doesn't get, you know, it gives you a feeling of, you know, going up in the air and all that. But that's not all. I think 3-4 hours it actually goes away. Blood, I have never been benefited with a blood testing. One thing for which we may say is for medical legal aspects. Medical legal aspects, I wonder, I do not really follow that up to that extent. Ashish may be doing it because he looks after emergency. But medical legally, if you haven't sent it, police will catch a token name. But if you have sent it, it actually doesn't help you out at all. So, what should you do? You must send it because police can create nuisance for you. Because unnecessarily you get drawn into the court and then answer a lot of questions which do not have any meaning to us. Like for example, Dr. Rupta said that you alcohol, methyl alcohol, PK, all is alcohol, you know, it's a nuisance value for which you must actually do it. Continue doing it until that value is settled, nuisance value is settled. Otherwise, it doesn't really have any meaning.
Sir has touched a very right point that to save your skin, you collect a urine sample and a blood sample, hand it over to the police person and that's it. Forget about it. You know, but there have been instances. One of my colleagues' wife was found unconscious and she was brought in and she was a medical doctor and she tested positive for benzo, but she also tested positive for cancer. Right? So there it helped us in management, which was important. So at times you may, once in a while, not always, at times you may benefit
Because
when
paracetamol we must diagnose because there is a treatment available today. Gunjan herself would be very happy to take up this case for example.
And paracetamol also, sir, serum levels are more important.
Exactly.
You know, so, and it has to be done 4 hours after.
So that,
Number 2, about we must send all samples for medical legal. You know, that's a must. However, I have attended as a witness or treating physician 10 cases in courts up to 10 years after the patient died. But not even in a single case I looked after the entire case sheet. Not in one case sheet they had answers to the samples those were collected by the police. I said, where are the results of those samples, examination or viscera examination? Not in one. So only they will catch you if you have not take samples. They are of not help. And clinically also by the bedside, as Dr. Ria said, they are no. I never depend on them, and they are not. At present, they are not useful.
so the positive, and even if the result come positive, your treatment is on the clinical grounds. So if it is positive both for benzodiazepine and opioids, there can be 3 situations. Patient has been poisoned by both. Patient is a chronic opioid user now with benzodiazepine overdose, or he's been taking sleeping pills regularly now come. So any 3 of the possibilities there, and you have to match it according to the clinical scenario of the patient.
I just have one more last comment to make on the medical legal aspect. We are still being governed by the rules which were framed in 1800 sometimes by the Britishers. They changed their rules. They have changed their rules, we haven't. When I was in England and I talked about these patients who were coming in with drug overdose or unexplained poisoning, they don't inform their police at all. They said, we'll only inform the police if the person is either attacking someone else, is a threat to someone's life, or is a threat to his own life. Then only we will, inform the police. Otherwise, there is no rule of informing the police. We still following the same rule. Suicide or attempted suicide, not suicide. Attempted suicide is an offense in India. It's not there in Britain.
Not now. They have removed that.
They have removed that, but in India, if they've removed it, then there is no need of even sending a police information. But the first thing when you call is as a witness, did you send the police information? Who sent the police information? How was it sent? Who has signed it? Do you recognize the signature? So these are the issues. I think we need to get out of this because, like sir said, 10 साल तक कोई सुनवाई नहीं होती और जब सुनवाई होती है तब तक आधा केस तुम भूल जाते. So when the test results are not there, I don't think there needs to be a change in this kind of a legislation.
So with changes in practices in toxicology or laws should also change.
And an important thing is these are all the screening tests. What we are talking about, these are all the screening tests. We are not confirmed. Okay,
Yes.
so that has got a very less legal values. We are doing all these tests for the treatment or diagnostic or the management perspective point of view. That might be false positive, false negative, or whatever the things. So that has got, yeah, Yeah, so that may have got a difference of opinion when if the person died and go to the forensic science laboratories, and after that they have got some confirmations, reports from the researchers. So these reports have a very less legal values.
So, although we've touched upon this, so if we cannot rely on the screening test, what is the value or limitations of the use of normograms or predictive curves in managing acute poisonings? Dr. Tejas?
Definitely, that's as we saw that there are many good screening the laboratory tests that is available. From the diagnostic point of view, that we must have to go for that. Some of the good labels that as we discussed the paracetamol label. If it has been available, we must have to go for that because that is a life-saving procedures for the management of treatment perspectives point of view. But if it is not available,
But they're not without limitations.
yeah, if it is not available, there is certain after 4 hours of injection that must have to be criteria. And if it is not available, then you must have to start considering the history of the patient that he or she had ingested the tablet paracetamols and exceeding the dose. Then you have to start the anesthetic systems without waiting of this kind of facilities to be available. So, personally feeling that we have to be on our eyes to be open and our senses to be relaxed to the point that if the person have taken, considering it and give the worst case scenario and start the treatment as per the situations available.
But they are also available only for its few drugs. There are only few drugs for which we have the plasma levels available, and they are only for the acute and single dose immediate release tablets. So we have to be cautious if the patient has a standard chronic intake of these drugs. We do not know the time, then it is not very helpful because the peak levels may have crossed. If there is delayed absorption or extended release tablets, or in at-risk patients like patients of alcoholism, malnutrition, where the plasma levels, the patient may be more toxic than the plasma levels. So management again comes back to the same thing. You have to prioritize the clinical assessment and symptoms based on the mental status, the acid-base status, over strict adherence to normograms. Although we have had enough debate, I think the message should go back to the attendees that does decontamination cause more harm than good in early management? I think, shall we skip this question, sir? Because we've had enough debate on this. So all the outcome studies who have seen mortality and length of stay, they have demonstrated superior or lesser complications rather than patients whom it was not done. So the risk-benefit ratio of gastric lavage must be weighed, and it is most in cases it is unfavorable, because even if you recover some in any situation, it is unlikely to improve the outcome, and it requires the airway control, and you cannot intubate the patient only because you have got to do a gastric lavage. So the message should be very clear that it is the only the airway protection is must before your gastric lavage is attempted.
Which we never do.
Which we never do otherwise. So again, what is the use of activated charcoal in the case of food poisoning when we can't do gastric lavage with this? Do you want to comment, please, sir?
Very few select indications, like we said, and only if you know that the drug has been taken, which has a sustained release, is likely to stay in the intestine for a longer time, drug causing pylorospasm. There is something which can be absorbed onto charcoal. Those are the only indications where you would use that. Otherwise, routine use should not be considered.
And as sir rightly said, the dose of charcoal required is also very high, 10 times the dose of the drug. So that is also a huge amount, and it is difficult to give.
Important thing is, anyone have seen activated charcoal in powder form?
It is difficult to give it.
I think.
Anyone have seen the activated charcoal?
We have used it a lot,
Yes, sir.
but we have stopped using it after 2014.
Because
it is so cumbersome to administer it to the patient through the eyes, to push it. Patient is already struggling, the treating team is already struggling. We do not have that kind of staff, we don't want to sedate the patient. And because a lot of time is, a lot of manpower is wasted. Instead, you invest that time, so important time, in treating the patient, resuscitating and administering the antidote, making a final diagnosis. These are the areas to be done. And we still are speculating on the issue of benefit, of charcoal administration. So it's best avoidable when you are in leisure time, you think that patient is fine, and there is strong evidence, as Dr. Bala said, pellets and with sustained release, then it is worthwhile to, you will not even have charcoal in your emergency room most of the times.
So, sir, just want to give you a message that whenever, sir, we are having an antidote bank, we will also store the activated charcoal in the antidote bank. So, if anyone needed, anytime, so because at present, most of the time it is available in tablets. So, as madam said, that 1 gram.
They are available in large tube form.
Sir, nowadays
Now
it's
powder is
powder.
also available.
So, the 1 gram per kg, you can imagine the 250 milligram tablet is available. 50 kgs person, and how many grinding and all these things you will need.
When we used to
Yes.
grind it with,
Yes, sir.
that drug grinder.
So now it is. Now it is in the powder form, so you can at least have a knowledge that this antidote or activated charcoal in a powder form is available. So you can connect antidote bank anytime when you can have access, at least so that you can have knowledge that when you use it or not.
If Dr. Gunjan would ask me one question, in any given situation, would you like to use charcoal, activated charcoal or not? My answer will be, I will not use it. I will not bother about it. So that will be my take. But there can be lots of discussion. You can have lots of.
One question I would like to ask all of us, that I did not use charcoal, was it instrumental in saving the patient or otherwise? I used charcoal, patient was saved, or I did not use charcoal, patient died. If we ask this question to us, we will not use charcoal. I think that's the message I would like.
Because it diverts us from other key important issues that are to be dealt at the time of patients. This is just a mnemonic to tell you fails, where charcoal fails. There is a whole list of these conditions. So, what are the most frequent pitfalls in the administration of antidotes? Where do they stand in acute management poisoning? The role of antidotes.
As I said, there are certain antidotes which are life-saving and which should be given immediately. Naloxone is one of the examples, and Atropine is another example. If the person is having severe bronchoria, and we know that food poisoning, it is bronchoria and the bronchospasm which kills along with bradycardia. So if you are rapidly atropinizing these patients now, what is recommended is, what is given in the book is, start with 2 to 4 milligrams and double the dose. If the patient is pouring out secretions from his larynx tube, will you still start with 2 milligrams? No, I will start maybe with 10 milligrams. And the next dose I will give is 20 milligrams. So guidelines are that you can start with minimum possible dose and go on doubling it. But if I start with 2 milligram and I double it and reach 36 or 40 milligram at some stage, it will take me maybe 10, 15, 20 minutes. But if there is a severe poisoning, I'll start with 10 milligrams and the next dose is going to be 20 milligrams. I might be able to achieve complete atropinization. Right? Similarly, like sir said, naloxone. What dose are you going to give up? Are you going to give 40 or 80? It depends on how rapidly you want the patient to come back. You can use 80, you can use 40. What is recommended is 40 and then you use 40 again and you use 40 again. You use 80 also. It all depends on how severe you assess the patient. So these are two important things. Soda bicarb is again important. Anti-snake venom is again important. Right? So these are the important things which have to be given immediately, where the antidote becomes a priority.
I'm saying. like while managing snake bite, lot of doctors they give 2 vials 6 hourly, 2 vials 8 hourly. All this is a useless thing.
Yes.
Aim is to neutralize the circulating venom. So doctor has to be, you should pour, I will use the word pour ASP. 10 miles, 20 miles, if patient is dying, and while you are applying your own regime 8 hourly, 12 hourly, so in snake bite also there is a golden time.
Golden.
But my general comment is, considering all these comments, clinical medicine should not die. Doctors are some clinical medicine.
Okay.
We are treating patients and not the reports. Because I am placed at the root level, I don't have facility to take all these investigations. So if and majority cases are diagnosed as per the history only.
Yes.
If duty of doctor is that he should not allow clinical medicine to die.
You see, antidote administration is single most important intervention in management of poison. To avoid any pitfall problem in management of poisoning, antidote administration in your emergency room, first thing required is you should have a fair or a good knowledge of epidemiology of poisoning cases in your area. Like in Rajasthan, in Jaipur, as I said, we have 5 commonest poisons. So we have a very simple rule. We rarely need naloxone, or we need mostly either management of acidosis. Metabolic patient comes with severe metabolic acidosis. The commonest condition is aluminum phosphide poisoning. You cannot avoid smell of aluminum phosphide poisoning. Phosphine gas. A patient will be emitting immense amount of the whole emergency room. In fact, paramedical scanning about 1 meter away would identify that there is a case of aluminum phosphide poisoning. It is unavoidable. If the patient is somnolent, his respiratory rate low, along with heart rate low, the patient cannot be aluminum phosphide. It has to be a neurological depressant. Mostly it may be opium or another drug, or might have consumed alcohol. Alcohol will also smell unless it has been a large dose of vodka. Then you have OP poisoning. OP poisoning, bronchoria. It is again unavoidable with bradycardia. Pupil constriction may be there with many other situations, but bronchoria is classical. So, good knowledge of epidemiological incidence of causes of etiology of poisoning is very important. Don't delay. If you are in doubt, you can do a atropine challenge test. If the patient is somnolent with bradycardia, there is no pupillary construction. You may inject a dose of naloxone. It is not going to cause any harm to the patient, but don't delay administration of your best understood antidote to the patient. That must be given, administered to the patient as early as possible.
Just added on this, my industrial aspects, because there are many industries, those who are having a different kind of chemicals. What I am using to have a different kind of chemical exposure. So whenever the person is having any acetonitrile, acrylonitrile, sodium cyanide, potassium cyanide, you must have to use anti-cyanide kit immediately, without failing. Amyl nitrate must have to be inhaled by the nursing staff when they reach to the hospital. Another thing is thermoglobinemia in industrial cyanosis. You must have to use a methylene blue without wasting time on the G6PD or whether that is available or not. Because in industrial setup, that is quite life-saving procedures. Many a times when the industries are on a remote places where there's kind of facilities, even a methylhemoglobin G6PD, nothing available. So you have a methylene blue, what we are usually doing is pushing methylene blue over 15 to 20 minutes directly. So that we can see, because in industrial setups, we don't have much time for any other things to do. First is the decontamination and use antidotes. If it is available for any chemicals to be used at that particular industry. So like that, we also required antidotes on time, which may be a lifesaver.
I just have, since I read the last slide, so I'll tell you a very interesting story. There's a patient who came to us. He was having arsenic poisoning. And when we took the history, he said he was taking opium. Now, opium is normally, it is, kind of cut with lead to make it heavy. But arsenic, very rarely they put arsenic, very rarely, not common. So I asked him how long he's been taking, he says 6 years. And since when he's having symptoms, 6 months. Fine, did you change your person from where you were buying your opium? So no. So, okay, then what happened? He went to one medical college and his symptom progressed inside the medical college. And then he was referred to us. And we were looking for the antidotes. It took us time. By the time we just hydrated it. And his symptoms started improving on their own. I rang a bell, something is wrong. I said, what happened 6 months back? One is, did you change your person? Said no. And then what happened? So I got married. Okay. So when you were admitted in the medical college previously, who was bringing food? Said my wife. He said, now you are here, who's bringing food? My mother. So the only thing has changed is, he's married 6 months back, and his wife was bringing food. He's having arsenic poisoning. The symptoms were progressive when he was in the hospital. He had not consumed opium in the hospital. And when he came to us, the only thing which had changed was his wife was not getting him food. So I'm just telling you, that the reason why I asked him this question was, were you consuming opium at that hospital? No. Are you consuming opium now? No. So opium is out. So there is some other source. And the other source for arsenic, I don't know how many of you know. Have you heard about arsenic album? Arsenic album, homeopathic medicine, sold as a tincture. It's a white, colorless liquid, has no smell, nothing. And if somebody adds that strong tincture to your food and gives it to you, you can develop acute poisoning. So, you have to sometimes go beyond being a medical doctor and work like Sherlock Holmes to find out what is wrong, where it is wrong.
So we can correlate, we have a similar incidence, a wife putting a arsenic brick in the water tank.
We had a very interesting case. This is about 25-year-old story. We had a organophosphorus case. He was on ventilator for almost 1 week. He was a patient from poor family, and they were having problems with charges those times, 25 years back. But he recovered fully, and while we were shifting him to wards, his wife insisted on transferring him to a room. So he was transferred into a room. The next day, the patient came out running that there is a snake in my room. If cobra was detected in this. So, obviously, he had visited him just before he detected that particular snake in this room. So, and we had a girl only 6 years back in our hospital. She recovered from aluminum phosphide poisoning. She was sitting while we were planning to discharge her. Her relative said we will take her tomorrow morning, and next day we found that she was vomiting huge amount of copper sulfate and she collapsed. The copper sulfate you cannot miss. the color. See, you can make out from a distance that patient. So you never know what is happening around you. You have to be very careful.
So similarly, sir, we are also thallium exposures. Two cases recently we have been come across with the thallium exposures, and we use the crucial fluid that also. And one interesting case, as you said, the one female had taken, she wanted to commit suicide, put some cuts on the radial, and she was not making her mind and committed with hanging, partial hanging, but admitted with severe hypotension. Acidosis. There was not that much blood loss of the oxygen, hypoxic damage. But she put the aluminum phosphate tablets into the vagina. So many times, exposures routes that we never know the person want to commit suicide and put this kind of tablets.
So, WHO, thank you for sir.
Yes, I want to discuss one pitfall while managing grade point. Sir, I need opinion of Dr. Bhalla sir. Sir, if patient of grade bite may take 2 to 3 hours to develop signs. Patient is here, grade is there. ये सूर्य है, ये जयद्रथ है. Patient has no signs. Lot of people, doctors in India, they take this as a dry bite and they wait for 2 to 3 hours. Suddenly patient collapses. So level dry bite in grade is very dangerous. So my policy is if grade there, patient is here, even though he has no neuroparesis, I will pour ASV. So what is your policy, sir? Bhalla sir?
There are subtle signs at times in grade bite which are often missed and may not be neuroparalysis up front. One of them may be paresthesia at the site
Yes,
of
sir,
bite.
perioral.
If you have paresthesia, if you have perioral tingling, if you have change in taste, very important. Every one of us must have experienced during COVID time what happens to taste. You know, you lose taste.
I mean, this case here.
If you have something like that, minimum possible, you go ahead and treat it. That may be the first sign.
Grade and watch phenomenon is very, very dangerous.
It is dangerous, but if you are, as I said, any snake bite, any poisoning patient should be in intensive care, should be ready, because if things go wrong, they might not give you time.
Definitely. So this happens generally with grade.
Yes. I haven't used it. There are
They are not responders.
No, these are premixed combination of neostigmine with glycopyrrolate, which people are recommending now. Grade bite, there is no use. We have concluded.
It's a proved grade bite, don't use it.
Don't use atropine neostigmine, but if you have some doubt that there could be a cobra, bite cannot be there without local signs.
Definitely.
You have to have local signs and neuroparalysis. Use atropine neostigmine. You have no signs, only neuroparalysis. I will not use. There is nothing as of now, but they are mostly biotoxic and some of them can be neurotoxic. ASV is not used for
this ASV has a paraspecificity.
You can't use ASV for hump-nose viper, you can't use ASV for green pit viper, red-neck keelback, which is there in Assam again, you can't use. Some of the other viper species which are there in southern part of India. You cannot use this ASV. So this ASV is limitation. But as I said, even if you do not have ASV, just supportive management, patient will take a little longer time to improve, but patient will improve if you support the patient.
But in viper cases, if you don't consistent ASV,
Oh, it can cause significant renal failure, significant hemolysis, pituitary necrosis. You need
Sir
to
is
give
saying is
ASV,
true
but-
regarding neurotoxic bites.
Yes, neurotoxic bite.
But generally, we think that they are myotoxic.
we follow.
But there are sea grades. A good swimmer dies of drowning because of grade bite, he is paralyzed, he can't swim. But sir, people have, one case was reported in king cobra bite, That patient responded to our routine ASV polyvalent.
Could be some cross.
Paraspecificity is there. Parasensitivity, I will say.
Don't disturb ASV before you see appreciate first sign or symptom of snake bite, disease.
Sir, that this is true about cobra.
When we do not know.
Unknown bite, you will have to wait.
Unknown bite.
That we can label as unknown bite. But crude correct bite is very dangerous to wait.
Times in our area, in Jaipur city, we do not have.
We must do. That's so unknown bite is a different thing. Few of them get turned to the snake bite.
So for antidotes, your epidemiology of the area where taken point should be taken, and for the rare poisonings, it should be nationally stockpiled and the effort taken by W4C there. So we carry on further or sir, we stop? So just the last question I want to ask to the panelists: why do these pitfalls happen? So last question.
Why do pitfalls happen?
Yes, why do these?
When you stop using your common sense. When you stop using your brain, when your eyes don't see,
You are confused.
and when what your eyes don't see is what your mind doesn't know.
Doesn't know.
If your mind doesn't know what you are looking for, you'll never see even if it is lying there. You know. So
Lack of awareness and training.
idea about this is
Awareness and training. And so this is one of the efforts in the toxicology.
Lack of knowledge, fear, experience, and use.
Thank you very much.
So, we need to manage one question very quickly because duty खत्म हो रही है ना, फिर जाना है. So, इसी में तो सब रोल होता है. So, I need five staff. Come on, hurry up. One team leader. Okay, give me one team leader. हाँ. Break पे हो चाय पीने जाओ. Okay. That's good. Come on. Why don't you be team leader? Yeah. That's okay. Select your 4 team members. दो इधर से दो इधर से. दो लेफ्ट से दो राइट से. दो राइट से दो लेफ्ट.
You can hand over, you can have. Thank you.
एक्शन दोगे मेरा तो आगे अभी ऑडियंस में खड़ा
इतनी बड़ी टीम है, इतनी बड़ी टीम नहीं होती कभी. छोटी करो. Let's be realistic. Let's be realistic.
Now I give you some tips. Team आपस में introduction, then pick up the roles in terms जिसको जो अच्छा आता है उसको उस काम के लिए रखो, उसको इस काम के लिए रखो, मुझे जितने सर्जिकल इंटरवेंशन कराने होंगे, कोई एनेस्थेटिस्ट कोई उस तरह से करो। इधर से लोग ये इसको इस पर कोई सामान लेके आएगा, ही नोज हॉस्पिटल में कहाँ सामान है, फिटिंग तो सामान नहीं मिलेगा, एक जने को रखो जो पता है कोऑर्डिनेट कर सकता है, बिल्ड अप ऑन द टीम सो दैट यार किससे यार ले रहा है।
कंसीडरिंग कि हमारा पेशेंट पहले इमरजेंसी में आता है और मेनली हमारा होता है स्टेबलाइजेशन और वाइटल्स चेक करना, बिकॉज अगर हमें पता ही नहीं है कि क्या चीज़ डिटेक्ट कर रही है, हम डायग्नोसिस सेकेंडरी हो जाता है, हमको नहीं पता होता एकदम से। तो फर्स्ट चीज़ होता है कि हमें वो लोग चाहिए जो कैनुलाइजेशन कर सके, पेशेंट को एकदम से में कुछ इंजेक्शन देने के लिए स्टेबलाइज करना है। एक स्टाफ चाहिए जो बीपी देगी और डिपेंडिंग अपॉन पेशेंट की स्टेट कैसी है, कॉन्शियसनेस, एक चाहिए जो आरबीएस चेक करे। मतलब हमारे पास तब तक वो जो ब्लड सर्कुलेशन जो हो रहे हैं वो मैनेज कर, जब तक हम देखते हैं कि एयरवे पेटेंट है कि नहीं है, सर्कुलेशन के साथ चल रहा है, हाँ मतलब हम देखें कि क्या चीज़ है जो आगे और उसको कॉज बन रख रही है उस डिटोरिएशन का। और एक हिस्ट्री ले, एक पेशेंट को बोले गार्ड, मतलब गार्ड भी इंपॉर्टेंट रोल प्ले करता है इमरजेंसी में, बिकॉज देयर इज लॉट ऑफ पीपल असिस्टिंग दी वरीड अबाउट द पेशेंट। तो हमको ऐसा चाहिए कि जिसको पता है कि एक्चुअली में क्या हुआ है, जो रिलायबल, बिकॉज कभी कभी कोमोबिडिटीज़ भी होती हैं जो कॉज बन जाती हैं उसका, तो हमें वो भी चाहिए जिसको पता हो कि कौन सी है, क्या जो है उसकी फिजियोलॉजी और पैथोफिजियोलॉजी रही है पेशेंट की। तो ये चीज़ हमें मेन चाहिए। और एक स्टाफ चाहिए जो हमें सीनियर कंसल्टेंट चाहिए होता है, जिसको हमें पता होता है कि अच्छा ये केस कार्डियो का है, केस फिजिशियन का है, ये सर्जन का है, तब उनसे हम कांटेक्ट कर सकते हैं। तो ये बेसिक है। तो अगर अभी ये पेशेंट हमारे पास आया है, सो व्हाट आर द सिम्टम्स, लाइक व्हाट आर द मेन, इज कॉन्शियस और नॉट, हिस्ट्री।
हम इसको लेके आए थे तो अपना काम खेतों में करने गए, सुबह गया था, शाम को लौटे नहीं है, उठा के लेके आए हैं।
तो ये क्या किसी चीज़ की दवाई खाते हैं, शुगर की, बीपी की?
कुछ नहीं खाते हैं,
कुछ नहीं खाते। एक जना इसका आरबीएस चेक करो, एक जना इसको वाइटल्स लगाओ और बाबा वो करो। बाबा इसका बीपी वाइटल्स और आरबीएस चेक करो बाबा जी, और उनको पल्स चेक करिए, ही स्टिल हैज पल्स। तो बॉडी चेक करिए, कन्नर लगाइए, चेक करिए, और एक जना चेक करिए बाइट मार्क्स के लिए, बिकॉज वो खेतों में बैठे तो कोई स्नेक बाइट या स्कॉर्पियन बाइट या किसी बाइट हो सकती है। किसी चीज़ की हिस्ट्री तो नहीं है ना कि ये कोई ड्रग ओवरडोज करते हो या फिर कुछ
पता ऐसे तो नहीं करता, रोज ही आता है। तो आज सुबह से गए हैं, आज झोला लगाने का टाइम था, लगाए हैं।
इनका चेक कीजिए,
इनको बीपी लगाना है, एसपीओटी दिखाना है,
इसी से
वाइटल सारे लीड्स वगैरह में
वाइटल
एसपीओटी दिखता है, सबसे मेन वो है। टर्म देखना है कि अगर पीछे नहीं जाएगी तो पेशेंट को, हाँ
वाइटल शो
एसपीओटी। पल्स हो रही है, कैरोटिड पल्स फील हो रही थी,
कैरोटिड हो रही है, पेरिफेरल नहीं भी हो सकती है,
बीपी लो हो सकता है,
देखो ना
कैरोटिड थी, मैंने चेक किया था।
ऑक्सीजन लगानी पड़ेगी मैम,
लगाना पड़ेगा,
ऑक्सीजन लगानी पड़ेगी।
बीपी कितना है?
बेबी मॉनिटरिंग कर रहा है, अभी कॉफ लगा हुआ है।
बाकी विटामिन कर लेते हैं, ऑस्कल्टेट कर लेते हैं कि एयर भी क्लियर है कि नहीं है। कोई मार्क्स के साइन है? 5 मार्क्स है, ठीक है। तो अब हम इस पता चल गया, कंफर्म हो गया कि ये स्नेक बाइट, पर बीपी बताना, बीपी आया नहीं हमारे पास, कितना है बीपी?
ऑक्सीजन लगाइए इनको, फटाफट ऑक्सीजन लगाइए, ठीक है।
हाई फ्लो मास्क।
तो अब हम फ्लूइड लगाएंगे,
बीपी भी लो है मैम,
बिकॉज हाँ फ्लूइड लगाएंगे टू रेज द बीपी। और एएसवी का
ये मार्क क्या चीज का मिला आपको? स्नेक बाइट, स्कॉर्पियन बाइट?
हाँ, पर ये है 2 बाइट्स है ना, तो मोस्टली पॉइजनस हो
तो
सकता है।
एक एट्रोपिन भी देना पड़ेगा यदि स्नेक बाइट है तो।
फिर एएसवी का प्रोटोकॉल शुरू हो जाएगा, हम मल्टीपल वाइट्स हाँ वो तो हमने पहले चेक कर लिया था, बॉडी चेक करने को बोला तो उसमें
हेड
ब्लीडिंग है कि नहीं है, फिर एग्जामिनेशन पहले
बीपी कम है इनका,
हाँ
एसी लोड करके मैम
हाँ
अपन ने बोला
दे दीजिए,
ऐसे लोड कर
लगा दो।
और फ्लूइड भी लगाएंगे साथ साथ।
लोड लगा दे। 5 मिनट बोला सी इनको दीजिए बैठ फटाफट।
और नहीं है नहीं नीचे से लाने पड़ेंगे।
बढ़ाने की थी।
रिहाइड्रेट करके हम पहले पीएस पे
हाँ, एक बार ECG कर लेते हैं।
बोलस लगा दिया।
कितना अब वाइल्स लेके आइए जो और पेंडिंग है, बोलस लगाइए फ्लूइड।
बोलस लग चुका
क्या
है 5
1000
मिनट।
ml हो गया। बढ़ाने की थी।
रिकंसिडर करेंगे ना बीपी, वो तो प्री बोलस बीपी।
क्या हो गया?
अभी तो पेशेंट स्टेबल है, उसकी हार्ट रेट भी है, पल्स भी आ रही है,
बात
बीपी भी
क्यों
बढ़ा
नहीं
है।
बात क्यों नहीं
उनका इंजेक्शन वो हो गया कहते हैं, वो खेतों में गए होंगे, तो स्नेक बाइट का केस हो सकता है, इसलिए वो कॉन्शियस नहीं हो रहे हैं। आप चिंता मत कीजिए, इसका एक एंटीडोट आता है, हम ट्रीटमेंट देते हैं।
ठीक हो जाएगा बिल्कुल।
जी, अभी तक बीपी अब बढ़ने लगा है, बीपी बढ़ने लगा है, तो जल्दी से रश करने को बोलेंगे।
लेकिन बट ऑक्सीजन नहीं बढ़ रहा है। ऑक्सीजन
बट मेन होगा कि हमारा जो ASP ने क्या चार्ज करना है लोड।
इंट्यूबेट का पान रखते हैं फटाफट, क्योंकि अभी तक ऑक्सीजन
अभी कोई जरूरत नहीं।
अभी तक ऑक्सीजन नहीं बढ़ा है, क्योंकि हो सकता है कि
टंग चेक करेंगे कि वो तो नहीं करेंगे।
एकदम से इनका बीपी और ऑक्सीजन लेवल लो हो जाएगा।
वायल्स आ गई है, वायल्स दे दीजिए। लगा दीजिए। बाबा जी
जीसीएस लो लग रहा है, अबाउट 10।
अब इंट्यूबेट करेंगे। ASC देने के बाद भी कोई सिग्निफिकेंट चेंज नहीं आ रहा है GCS में, तो अब इंट्यूबेट ऑक्सीजन MB बाक्स पे आइए।
किस तरीके से हम नीचे भेज दिए
सर्कुलेशन फ्लोटिंग तो नहीं है इनका।
अरे मान लो है तुम्हारे पास है, दो साइड में रखा हुआ है।
बस तो स्टार्ट करेंगे, लेरिंगोस्कोप और प्रिपरेशन स्टार्ट करिए।
इंट्यूबेट करते हैं इनको फटाफट।
इंट्यूबेट कर दिया आपके इंट्यूबेशन
20 पे आ गए ना।
हाँ रेस्पिरेटरी बढ़ गया।
सर ऐसा हो सकता है, इंट्यूबेट मैंने कर दिया और इसका हो सकता है ABG मैंने भेजा है, हो सकता है इनको मॉनिटरिंग के लिए सोडा देने के बाद हो सकता है इनको मॉनिटरिंग के लिए ICU में शिफ्ट करना पड़ेगा 24 आवर के लिए। फिर मैनेजमेंट के उसके आधार पर ABG आने के बाद फिर मैनेजमेंट देखेंगे,
ठीक हो जाएंगे।
हाँ ठीक हो जाएंगे,
बिल्कुल ठीक हो जाएगा ना।
जी
बिल्कुल का तो नहीं कह सकते, अभी ऑब्जर्वेशन में रखेंगे 24 आवर्स के बाद पता चलेगा।
सर ICU का खर्चा
रिसेप्शन वाले बताएंगे।
फिर आप 24 घंटे बाद और पैसे मांगोगे, फिर
आपको पेशेंट की जान ज़्यादा प्यारी है,
पैसे मांगोगे देंगे कहाँ से आप? खेत से तो उठा के लाए हैं।
पैसे जितने देंगे उससे पक्का ठीक हो जाएगा।
पक्का तो कोई गारंटी नहीं होता है, 24 आवर्स क्रिटिकल पीरियड होता है, अभी ऑब्जर्वेशन में रखेंगे, उसके बाद जैसे इम्प्रूवमेंट होगा या नहीं होगा वो आपको अपडेट देते रहेंगे।
और पैसे भी लगेंगे
उसके बारे में लग सकता है, आपको रेडी रहना चाहिए। अगर आप रेडी नहीं है तो और भी आयुष्मान कार्ड वगैरह तो हम रेफर भी करते हैं। सीधा ये होता है बिकॉज पेशेंट की लाइफ ज़्यादा इंपॉर्टेंट है। अगर हमारे पास वो भी फाइनेंशियल क्रंच में, अगर हमारे पास नहीं है फैसिलिटीज़ तो हम रेफर करते हैं। अब पेशेंट
रिकॉर्ड देना सर।
एक बार बीपी दोबारा से चेक करेंगे। वो तो इन्वेस्टिगेशन देंगे।
पेशेंट को टैकल हो गया मैम।
क्या हो गया? क्या हो गया मैम? इनको कुछ हो गया मैम?
दवा दी है ना, उसका भी रिस्पॉन्स हो सकता है। ASB
क्या हो गया?
ASB से हो गया, ADR भी तो हो सकता है।
क्या हो गया?
आप थोड़ा ये अभी हमने दवाइयाँ दी हैं ना, उसका साइड इफेक्ट भी हो सकता है। अभी तो एक्सपर्ट
एरिया से सेटल करो। हाइड्रोपोटेशन एंड लिविंग।
सांस कैसे ले रहे हैं?
सांस तो ठीक है, वेंटिलेटर से दे रहे हैं, तो आप उसकी चिंता मत करो, वेंटिलेटर से वो ठीक हो जाएगा, सेट करेंगे। पहले भी हम, क्योंकि जो हार्ट रेट है वो एसबी देने के बाद एकदम से बढ़ गई है, उसको सेटअप करने की कोशिश कर रहे हैं हम लोग।
वो कैसे सेटल होगा?
दे रहे हैं, दवा दे रहे हैं शॉप।
बीपी डाउन,
बीपी डाउन, नोरेट पे लेना पड़ेगा। हार्ट रेट इज कंटिन्यूसली हाई। ईसीजी निकाल, एक डबल ईसीजी ले लेते हैं। डबल स्टैंड नोरेट ले लो और एक ईसीजी देखते हैं इनका।
बहुत ही फीवर
because BP is below. I feel low.
एक लीटर बोनस दे दिया।
कोई नहीं, just clear है दे दो। No, नहीं आइडिया सर, वो एसबी देना, एसबी से
क्या करना चाह रहे हैं?
नहीं एडवांस रिएक्शन भी कर सकता है।
क्या करना चाह रहे हैं?
नहीं सर वो दे रहे हैं, एबी का एक्सपर्ट दिया है सेटअप।
एबी हाइड्रोपोट दे
Peace, good.
Very nice.
कुछ तो हुआ, कुछ तो हुआ। Okay. Thank you. How do you feel after थोड़ा और ज़्यादा की डेफिनेशन नहीं, थोड़ा सा लगा कि पेशेंट सेटल हुआ, टेस्ट भी दिया हमने, एकदम से एडवांस रिएक्शन जो आया उससे इसके बाद सारे बीपी लो हो गया, हार्ट बढ़ने लगा, इस पर थोड़ा हमें लगा कि पेशेंट
To be honest, a little confident because before that I lacked confidence. So saying things out loud, I was like, okay.
That is what the purpose is.
Yes.
तू गलत कर नहीं बिल्कुल patient attendant confidence. So what are the things you believe that sir, as soon as the patient we try to respond as early as possible. We check all the vitals, we did what we want to do to secure the airways and to find out the cause of his unconsciousness. उसके बाद सर we find a fang mark, so we suspect that is some type of unknown bite, that can be snake bite or scorpion bite. हिस्ट्री से भी थोड़ा सा मैच कृष्णा सर के फील्ड में काम कर रहा था सर, अराउंड मंथ्स पड़े हुए थे। और कुछ अच्छा किया हमने कम एयर भी हमने सिक्योर किया। और ओके अटेंडेंट काउंसलिंग any other points हम कुछ बेटर कर सकते हैं कि अगली बार यही पेशेंट ऐसा आएगा तो हम कुछ डिफरेंट कुछ अलग करना चाहोगे अगली बार अगर ऐसे ही
चेक करके रखेंगे कि हमारी जो ASC वायरस है वो कंप्लीट है, ताकि डिले ना करना चाहिए।
I may defer to that because I cannot force you to keep your ASV. Yes. Everywhere a set of 10, but what you need to know is कि मेरी बिल्डिंग में स्टॉक कहाँ पे है। Yes. You can't expect कि पेशेंट घुसेगा तो अपने साथ दवाई साथ लेके आएगा। मेरे को ये दवाई
what you need to know is कि मेरा stock कहाँ से आता है. So I'll get a stock directly from there. So there is no confusion and delay is minimized. Right? So while कहीं से भी उठाओ लाना पड़ेगा 10 वायल का ऐसे नहीं होता एक दूसरी सिरिंज पंप में लोगे या फ्यूज में it will take time. That's easy.
One thing is to be ready for the competition.
I have 2 comments to make because 5 o'clock we need to sit there. One is, what was your first reaction for yes, what you wanted to do? अंदर होगा, ठीक है। क्या अंदर होगा? ठीक है क्या? फिर ठीक कैसे होगा? What is the reaction? What is the reaction? और एनाफाइलेक्सिस। अगर एनाफाइलेक्सिस है तो क्या देंगे?
नहीं
अगर एनाफाइलेक्सिस है तो ट्रीटमेंट प्रोटोकॉल में सिर्फ
ADR
बाकी सब चीज़ें जो हैं हमारी विंग्स एंड फैंटेसीज की हैं, उनका कोई इमीडिएट रोल नहीं है।
We have history of earlier development and we can also be before starting of phase 3.0.
हाँ मिलेगा वो अभी तो एक ढूंढ के निकाला है, पिछला कहाँ से ढूंढेंगे कि पहले भी था, वो बाद में आएगा। बट हमारे प्राइमरी सर्वे में एक मार्क मिला एड्रेनलिन का भी रूट है क्या? अब वो क्यों है? उसका बड़ा सिंपल रीजन है, कहीं भी उस प्रोटोकॉल को पढ़ोगे तो उसके नीचे स्टार इधर हम तैयार हैं, उसके नीचे लाइन लगी हुई है कि अगर आईवी लाइन है तो आईवी भेजिए, और वो इसलिए लगी हुई है कि अगर आईवी बोला गया तो आप आधा घंटे तक इस मरीज में आईवी ढूंढते रहते हो और उस मरीज को एड्रेनलिन नहीं मिलती। तो अगर पेशेंट के आईवी सिक्योर मैं कर चुका हूँ तो मैं आईवी लगाने के लिए स्वतंत्र हूँ, नहीं तो फटाफट सब तो मेरा को डिले। एक पॉइंट रह गया मेरा कम्युनिकेशन का, उसको सब लोग मेरी अपनी तरफ से सोच के आएंगे कि इस सिनेरियो में जो कम्युनिकेशन हो रहा था उसका क्या अच्छा पार्ट था और क्या इम्प्रूव करना है, और वो हम कल ठीक है। लेट्स गो।
ना,
किस चीज़ का?
जो बाहर जाएगा
ये लाइव चल रहा है
लाइव, जी जूम पे जाएगा ना।
जूम वाला सर वो सामने
अच्छा वो ये नहीं दिखेगा ना हॉल।
आईडी बताइए।
से हमारे सीनियर और रेमिनेंट स्पीकर्स टीचर्स आए हैं, सभी को मेरा नमन एक बार दोबारा से। और जितने भी डेलीगेट्स हैं एंजॉय कर रहे होंगे। मेरे ख्याल से जो ज्ञान है ओवरफ्लो हो गया, इसलिए वो सब निकल गए कि अभी शायद बुलाया है दोबारा, कुछ लोग निकल गए हैं नीचे ही थोड़ा। तो मैं सबसे पहले तो जितने हमारे आज के स्पीकर्स हैं और स्टेज पे मैं इनवाइट करूंगा कि सब लोग बैठें। सभी आई कांट सी द नेम्स, को बैठना है।
डॉक्टर बनाम्बर रे, डॉक्टर पुंडे, डॉक्टर भल्ला। I will request Dr. Anuj to please take your chair. हमने बहुत गेस्ट को रिक्वेस्ट किया हुआ है ऑनलाइन ज्वाइन करने के लिए और उसका समय 5 बजे दिया हुआ है। We wish to start at 5 o'clock and we may deviate from the routine procedure and formalities of the meeting, formal meeting, inaugural function, and straight away we'll start with business. So may I invite Dr. Anuj Singhal, Secretary Swami Vivekanand Mission Society, Health Mission Society. He is the one man who manages 14 shrine destinations, health centers in Uttarakhand and outside Uttarakhand. He is always on wheels, and you have seen the institution here, and you see what he is worried about clinical care of the patients around this area. He is worried about progress of medical profession in this hospital and progress and development, skill and knowledge development of our doctors and nurses here. So this is a continuous exercise. I invite Dr. So lots of people may be connected to us online from inside outside India. So I request Dr. Anuj to deliver his address.
Are we live? So dignitaries on the dais and off the dais. So and doctors and other participants who are linked with us online for this very important session on our target to zero mortality due to poisoning in our country, Bharat. So maybe few delegates, few invitees are from outside also. So that's why I am speaking in English also. So first of all, I would like to welcome our esteemed guest from all over the India, Dr. Valla, who is the father of, we should say, in Bharat Toxicology. At present, he is professor and HOD PGI Rohtak, that is government. Chandigarh, sorry. And Dr. Maharashtra from Dr. Tunde has come. Recently, he was called by our Prime Minister Modi. He is one of the 11 president, one of the 11 doctors from all over India who was felicitated by our Honorable President of India, Srimati Draupadi Murmu, and our most senior and most knowledgeable and valuable Dr. Panambar Rai. It is his second visit, and we are getting his blessings always. And the forerunner, or I should say guide and mentor of our hospital as well. And for this all clinical workshop, Dr. Naren Grunta, a known eminent critical care specialist of world renowned critical care specialist, sir, and who has offered, we are honored to have his services in these remote areas, and we are trying hard, so not catching his speed to develop our critical care and poisoning institute here. Thank you, sir. So I would request our doctors also to please at least follow his path so we can improve our practices, critical care and other services also for the benefit of the patients. So I would welcome other doctors also. Just in 5 minutes, what we are doing, Swami Vivekanand Health Mission Society, in 2012 in a small shop, rented shop, and then gradually with the help of whole team, we have a big team, 1,000 doctors and other philanthropists who are always with us day and night. Because of them, now we are running 15 charitable hospitals, 12 in Uttarakhand and 3 outside Uttarakhand, 1 in Delhi and 2 in UP. Our biggest project is coming in 500 super specialty hospital and 200 bed cancer hospital, which would be most probably in October or November this year. And special project is our Chardhan hospitals. We have fully equipped, even we treat MI also there, all type of critical cases there at Sri Kedarnath Dham, Sri Badrinath Dham. Kedarnath Dham alone, we treat daily around 27,000-28,000 patients per day, and out of that, around 300. Now, this year, we are starting our new hospital there, 50 bedded, with ICU and ventilators, everything. I would like to invite you also to come there and see that hospital, and if possible, serve it. So you will be very happy to see those hospitals, and it would be worth to visit. So I humbly request all of you to come and join us in this service talk. Already most of the doctors are doing, but at this altitude around 12,000 feet, we are providing our services, obviously with the help of voluntary doctors. We have more than 400 voluntary doctors over India, and few from their free voluntary services at these centers. Kedarnath, Badrinath, and other hospitals also. One doctor till today he provided his services at Peopleputti, our hospital, on the way to Badrinath. He is a senior dermatologist from Bangalore. So 2 days at Peopleputti and 2 days at Narayanpuri. Every year he comes. So many doctors come here on the regular basis and provide their voluntary services and quality services. Not only voluntary and very good quality service, we also learn from them and we try to improve our services. And we have a lot of community works, health project also, like breast and cervical cancer screening program. And this year we are starting cervical vaccination program also in between 19 years age of girl, totally free of cost. And we are planning to cover first Dehradun district and gradually whole Uttarakhand. Our planning is to cover whole Uttarakhand, at least 9 to 18 years, right? Because maximum protection is in this age group. And then we have oral health cancer program also, anemia prevention and control program, community mental health program, and menstrual hygiene, menstrual pad program also. My pad, every month we provide free sanitary pads to almost more than 3,000 ladies and girls every month on regular basis. So, and after Rumta sir has come, so we are improving our academic and clinical knowledge also, and we have come on the map of India also as a clinical district of Dr. Rumta sir. With these words, I once again welcome all of you and would like to invite Dr. Rumta sir to give an introduction about this workshop. Thank you. Sir, PPT? नहीं.
So, greetings on the dais, my fellow colleagues, members of Swami Vivekanand Charitable Hospital, researchers, ladies and gentlemen. Good evening to all of you. Ram Ram. Today, as I stand here, it marks an important milestone in the journey in India of emergency and critical care medicine, and of course, public health. We are gathered here to launch a national campaign and program. What we have thought of zero tolerance to mortality in poisoning cases in our country. At a very first glance, it appears to be an arrogant and obvious thought. Some may think that it is too idealistic. But if you go back to the history, you will find that every big ambition or an important ambition or a milestone, initial thoughts were dreamy, high, and then you have to work on it with sustained effort and zeal. And there is no milestone which we cannot achieve. And the way I have got support, Dr. Rakesh Tyagi, I am sure we will be able to achieve what we have thought about 5-6 years back. Our Prime Minister also often says, "Sapne dekho, bada socho, aur bada karo." So we want to make a valiant attempt, a good effort to achieve zero tolerance to mortality in poisoning cases. We were making a national guideline for management of poisoning cases in India few years back. We also brought out a position statement about how to handle poisoning cases in India. You must have seen several references to that aspect during the day. We realize that the data that we have in our hands represents no more than a tip of the iceberg of the problem that exists in our country. If at all, it best represents urban data, metropolitan data. The rural or the semi-urban population has remained immune, untouched from this data. And most of our poisoning associated morbidities, they are in the rural areas, in the semi-urban areas, and they hardly come to the notice or to the statisticians of medical fraternity. Every year, lakhs of patients are dying. At any given particular time, more than 1,000 patients are admitted in various emergencies or ICUs in our country, suffering from poisoning consumption, which includes snake bites. Of late, drug-induced poisonings, addictions have also taken a given a huge hit to our young population. Therefore, it is needed, and they are all young, either breadwinners of our families or homemakers of families. And if there is a mortality in middle class, lower middle class, it virtually breaks the family. Therefore, it is important that if there is nobody to look after them, we should take the responsibility on us to look after them, prevent such deaths and their hospitalization. For too long, mortality in poisoning has been silent and has been accepted as a tragic but unavoidable outcome. But the truth is very different. Most of these deaths can be prevented or treated because they are treatable. There are many factors which can do wonders. Why I am saying so? And we have planned a 6-pronged approach towards this goal. Number one is identifying the ground reality. What is the ground reality? We do not know what is the ground reality. Which geographical areas are affected with particular poison. So we have introduced a software, and we are on to data collection from all nooks and corners of our country. The software is called Poison, means poisoning solutions, and we will register about 100 hospitals in the first year. Data entry has already been started. This hospital, Swami Vivekanand Charitable Hospital, has already spent about 10 lakh rupees in this process to construct this data software, and I am happy to say here we have successfully entered first 10 patient data. Once this data is entered from, say, 1 year from now, 1,000 hospitals will be recruited, and we have data of more than 1 lakh patients over a period of time of 1 year or more. We will be in a position to understand what is the actual real condition. Next is knowledge sharing and skill development. And today's workshop is one program in that direction. we have organized almost 20 of such programs in last 3-4 years on the platform of W4C Critical Care Foundation. Now that we are sharing our platform with a very important organization of our country who extends free health care to downtrodden, poor tribals in remote areas of our country, Swami Vivekanand Health Mission Society, I think we will be able to implement our thoughts, and it will result into actual outcomes that we have been looking for some time. So after these workshops, we will train as many as doctors, paramedicals, and we are also on to create awareness amongst general public, voluntary workers who can spread around into villages and small areas, convincing people that they should not hide their poisoning cases. They should be aware that most of these cases can be treated, and also will bring about knowledge to these villagers and farmers that it is better not to consume these poisons and do some preventive exercises. Number 3, so this will lead to development of evidence-based treatment guidelines, promote training and education of health medical professionals. This workshop today and tomorrow, is an exercise, and we have the best brains of the country. You have heard Dr. Ashish Bhalla, Dr. Punde, Dr. Ray, and you will hear many more of them tomorrow. They are best in the business. They have been our teachers. We have shared, learned a lot from them. So, Dr. Punde was saying today that he has brought down mortality of around 25% in his area in Maharashtra, remote place. Just one man team to nearly zero. Less than 1% you said, sir. So this is achievable, and I will request for you to clap for Dr. Punde. The third problem is most of these rural patients or semi-urban patients cannot reach, well-equipped healthcare centers or corporate hospitals. And the doctors and nurses, paramedicals, they are not competent knowledge and skill-wise to handle these cases. And therefore, most of these cases are referred or treated badly. And most of these patients would not go to the urban areas for treatment because either they cannot afford it or they are ignorant about it. Therefore, what we have done, we have developed a chat bot on our website which will be available for chatting for these medical professionals from rural or semi-urban areas or anywhere in the country to chat with any one of us. And 10 of us have joined together to give one duty in 10 days. 24/7 will take those questions in the chat with the medical professional, help them, assist them in treating the patient. Therefore, most of these patients would stand treated appropriately, and this will bring down morbidity and mortality vertically down. Number four is we will go to the government. We have pesticides and herbicides like aluminum phosphide and paraquat. Both of these pesticides or herbicides do not have any antidotes, and there is very high incidence of mortality because of this. So we will make an aggressive group within us and go to the government to invent a legislation, form a legislation whereby they will ask these multinational or national companies to make sure that they have antidote first in place before marketing any pesticide or insecticide or herbicide. any drug, chemical should not be allowed to be marketed and let poor people or farmers to let them die because there is no antidote. Friends, we have already started exercise on that. So, last we had Vivekanand Jayanti in January, 11th January. And Dr. Ashish Bhalla, I have been talking to you for some time that we are trying to develop a center of excellence toxicology. On Vivekanand Jayanti, Dr. Anuj Singhal made a public announcement that we have decided to develop a center of excellence about toxicology at this hospital. This hospital will act as nuclear center and we will store antidotes. We have already started the process. We today requested Dr. Ashish Bhalla to supply us omeprazole. We have collected almost all antidotes, but there is no end to prospective or possible antidotes. Today, Dr. Tejas was telling me about thallium-induced poisoning deaths in Delhi, and Persian blue is the antidote. So we still, have to travel a little far more than what we have done already, and we will make available for everybody, all the patients, all possible antidotes 24/7. They can collect the doses from here in coming times. So once this center develops, we are developing a huge ICU which will cater to these patients. We have stored lots of antidotes already. We are conducting workshops. We have developed a software where we are connecting hospitals, and we have also framed a chatbot. Ladies and gentlemen, this program of zero tolerance for mortality in poisoning is not a program of single institution. We are a team of 20 doctors from around the country. Each one have immense contribution already that he or she has contributed to the development of toxicology literature and skills during last 5-10 years, and I have been witness to that. The cooperation and partnership has to develop with all hospitals, all medical hospitals, all medical professionals who deal in toxicology. Therefore, I will call upon all hospitals, small or big, urban or rural, corporate or government or charitable, to join this campaign, register with our software and enter our data. It will not be only data entering hospitals or individuals, they will be actually our research partners. If we have appropriate data collection, we will be able to analyze exactly the problem and develop protocols and systems to prevent morbidity and mortality in coming times, sooner than later. A national poison register, evidence-based clinical guidelines, improved survivals, stronger public health policies, ultimately healthcare system which will be robust in preventing deaths. Let this program be the beginning of national movement of excellence in poisoning management. Let us replace fragmented efforts with collaboration, uncertainty with data, and preventable mortality with effective care. Together we can build a future where poisoning patients across India receive timely, evidence-based and life-saving treatments. Together we can move closer to the healthcare system that truly reflects the principle of what the program we are launching today, zero tolerance for mortality with poisoning in India. Ladies and gentlemen, thank you very much for your patience. Dr. Tara, Dr. Dr. Rajesh, who is not able to come today, my all colleagues who have traveled so far from their working places for this particular program. Thank you so much. It gives us strength, it motivates us. There may be a number of friends and well-wishers. Do I have the list of those who have joined? Can I call them and to make any comments if they want to? Vaibhav? Do we have any information? So we have a couple of them, and I have few confirmed. We have our friend Dr. Leelanthi Subhasinghe from Sri Lanka. Dr. Leelanthi, can you make a comment?
Hello, Dr. Dharmawala. You can hear me?
Yeah.
Can you hear me now?
You have 30 to 60 seconds to do that.
Oh, yes. Thank you very much for inviting me to join this event, and it's truly a great pleasure to be here as the President-elect of the Ceylon College of Critical Care Specialists, and also as one of the speakers at the upcoming conference. So yes, as you said, and as we all experience, poisoning is continuing to be a great challenge in South Asia, especially in India and Sri Lanka. I would say we share common problems. And in that sense, the vision of this initiative, zero tolerance for mortality, is therefore, I think, is very bold and necessary at the time. And initiatives like this can truly make a difference by bringing together all the specialists, like clinicians and maybe researchers, and also knowledge where there is to improve outcome. So from Sri Lanka, as I said, we face many similar challenges. We look forward to learning from and collaborating with our colleagues in India, as we have already done, especially using our clinical data together. We can make great publications and use the data we have to improve outcomes of patients. And finally, I would like to warmly congratulate the team led by Dr. Rupta, and I wish him great success in years to come in saving many lives together. Thank you.
Thank you, Dr. Leelanthi. We will invite Dr. Suresh Joshi, the former UNICEF representative in India. Dr. Suresh Joshi. Suresh, you are there? Dr. Nagaram, who is a NRI serving in Muscat for almost 20-25 years now. Dr. Naga?
Yeah, good evening, sir, Ramka sir, and good evening all faculty. Okay, am I audible?
Yes, please go on.
Yeah, so it is my honor to speak here. So, as all we know, poisoning is a major medical emergency in India, and it is mainly because of pesticide or chemical or sometimes overdose. The epidemiology is saying that death happening up to 30% overall. But in pediatric age group, basis and pediatric underweight, so I can speak on the pediatric case. So pediatric almost 5 to 7% of admission rate due to the toxicity, and as well as main age is the infancy to 3 years. And mostly the pediatric emergency, it is accidentally, not intentionally. And so a zero tolerance for mortality approach means that every poisoning case should be treated as a preventable, and this requires rapid diagnosis and timely treatment and availability of the antidote, as well as then healthcare professionals and strong poison information center. Since I am working in the Muscat, we have one number, the emergency board number, so we can call every time 24 hours. One person should be there, and they can answer and they can advise us the treatment what to do next. And as well as we have guidelines, and we have book on the emergency. Whenever the patient is coming, we can find it the treatment. So with better prevention, regulation of the toxic substances, and improve emergency care, many lives can be saved in India. And every poisoning can be preventable loss, and our goal should be the zero outdated mortality. In conclusion, every poisoning death is a preventable tragedy with coordinated effort from the health professional, policymakers and community. India can move towards a future where mortality from poisoning is minimized and every life is protected. And I would like to congratulate for the successful of this toxicology workshop. And thank you very much, sir, for inviting me, and thank you all faculty members.
Thank you, Dr. Nagar. May I invite Dr. Anand Mishra to make a comment? Anand?
Sir, good evening, sir.
Can you make a comment?
My happiest congratulations, sir, to Rumka sir, to Vanamar sir, and the entire team, sir, for organizing this. And I am Dr. Anand from Bhubaneswar Ultimate Medicare, though I am not physically present there, but my heart and soul is there, sir. And I am very happy that the brainchild of Rumka sir and the dream has come true. And I think a lot of effort has also been put into it to make it successful. And I think it's a golden effort to save human life. All of us get a lot of poisoning cases, but till now, at national level, such big initiative to tackle poisoning cases, to save human life, to make it available the antidotes as early as possible. I think it's a big step. And in future, I hope we need to reach out to people at periphery so that precious life can be saved. And I'm very happy, I'm privileged and honored to be a part of this toxicology team under Vanamar sir and Rumka sir and the entire team of toxicology. And once again, happiest congratulations to all of them and wish a grand success of this conference. Thank you, sir. Thank you.
Dr. Vinita Panigrahi Jamshedpur. Dr. Vinita.
Sir, good evening. Good evening to you, sir, Dr. Dharmawala, sir, all the members present in the dais, and all the attendees of this great conference. So I am indeed privileged to get this invite to join the inauguration online. And I am really happy that the glucose C has developed with such leaps and bounds, and the toxicology program that has been taken up is really one of its kind, and it has helped everybody, all those people who have joined. We have had seminars and panel discussion in the past, and it is the right step forward because we have to have a very good protocol-based approach to toxicology, particularly in the Indian ICUs and emergency, and that is the only way to bring down our mortality. We also have to look at a way in which we can reach out to the people coming from the poor backgrounds, particularly the farmers, how we can give them the best of treatment at an affordable price so that they don't have to go away from the good hospitals to other less resourced and less developed facilities, thereby taking a toll, the poison taking a toll on them. I think this platform is the best way to reach out to those people and also to give them an outlet as to where to seek the right treatment. I think we are on the right step, sir, with your leadership. I hope we will reach more milestones, and like you said, this forum is going to achieve very soon. I wish this conference all success. Thank you, sir.
Last one. So, if there is any person, any guest, any friend from remote virtual connections. I saw Mr. Suresh Gupta, former Chief Secretary of Government of Sikkim. He is still there. Suresh Gupta ji. Dr. P.L. Navlakha, former Principal, SMS Medical College, Jaipur. I saw him too online because of the technical problems. Probably it is a little difficult to... Anyway, I think I'll stop here since we are unable to connect to many of them. Thank you very much, ladies and gentlemen.
Problem will be protection.
हाँ नहीं वो देर से खाना है कि लाइक कर
May I request Dr. Ashish Bhalla, who is professor and head of Department of Infectious Diseases and in charge of emergencies, PGI Chandigarh, to say a few words.
Thank you, sir. I think this is a very well done effort, and I must thank Chindu sir for providing us the platform to launch this, and I sincerely wish that this hospital truly becomes a center of excellence for as far as the management of toxicology is concerned, and a great effort. You know, as sir said, you have to dream big. Sometimes those dreams appear silly at front, up front when you start with. But as he's got the knack of taking people along. He's got the knack of gathering people and taking them along. And I think we've seen that today. And I wish him all the success in this endeavor. I'm sorry I have to travel back, and I might have to leave now because otherwise I won't be allowed. So I would request you to give me permission to leave, sir, and thank you very much for having me here.
Dr. Punde?
Yes, sir.
Carry some memories of your visit, sir.
I would love to be a part of this.
We would be honored to have this type of trouble.
Dr. Punde, can you make your comments? 2 minutes.
Dr. Rupta sir, Dr. Singhal sir, Dr. Mullah sir, Dr. Ray, and you all. I am really grateful to Dr. Singhal and Rupta sir for giving this opportunity to speak in front of you. Sir, Swami Vivekanand Mission Hospitals, they are doing excellent all over the country. Even in Marathwada, we have one at Latur, Vivekanand Hospital. All these hospitals, they do humanity service with medical excellence and they maintain a human touch. Sir, you are launching a new app and we are collecting the data all over the country. Unless and until data is there, government can't plan anything. So today we have very interesting sessions. Swamiji कहते थे education means justice to the last man of the society. अभी भल्ला सर को जो सम्मान चिन्ह दिया गया उसके ऊपर अध्यात्म और विज्ञान लिखा था. So life is a good combination of adhyatma and vijnana. Spirituality plus science is a good life. Dr. Singhal sir is doing excellent. I wish all the best. Sir, definitely we will be actively participating for this national cause and definitely mortality because of snake bite and poisoning we will try to reduce because coming together is a good initiative. This is a feast. One finger can't do, but fist can do a lot. So I am really grateful to all of us. He is a good manager. Manager means he is a man, age, man and team. He manages all persons of all ages and all minds. I have seen him since last 6 months. So thanks for appreciating my work. But the real India lies in the rural pocket. So your work is for the last man of the society. A day is we are trying to justify a poor victim of poisoning and snake bite. I wish all the best and I offer thanks to you all again.
May I request Dr. Pramod Sharma ji?
सभी को राम राम। लास्ट पे बैठे सभी लुमिनरीज महानुभाव, डॉक्टर नरेंद्र गुप्ता जी, डॉक्टर कुंडे सर, डॉक्टर रे, डॉक्टर सिंगल, डॉक्टर तारा जी और सभा में आसीन सभी प्रोफेसरगण, मेरे अपने साथियों, मुझे बड़ा हर्ष हो रहा है यहाँ पे डॉक्टर रुंगटा के आने के बाद जो एक क्रांति आई है हमारे हॉस्पिटल के अंदर एक एजुकेशन की जो क्रांति आई है, जो ट्रेनिंग की क्रांति आई है, हमारे पिछले दिनों में काफ़ी अच्छे वर्कशॉप डॉक्टर रूमका ने कराए हैं। ईको का कराया है, अल्ट्रासाउंड का कराया है, क्रिटिकल केयर के अलग भी कराए हैं, और आज से टॉक्सिकोलॉजी का जो बहुत अच्छा सेशन हुआ है। हम लोगों को इसमें तो बहुत नई नई इन्फॉर्मेशन भी मिली है, बहुत सीखने को मिला है। और इसी के साथ साथ जो इस सब्जेक्ट के स्टैलवार्ड्स हैं उनके दर्शन भी हुए हैं। इसमें मैं डॉक्टर कुंदे का बहुत आभार व्यक्त करता हूँ कि इतने रिमोट एरिया में जाके इतने अपने सिंगल एफर्ट से इतना मॉर्टेलिटी को डाउन किया है, जो कि एक बहुत ही खतरनाक बीमारी होती है कि पॉइजनस स्नेक अगर काट लेता है तो बचाना मुश्किल हो जाता है। लेकिन मैं डॉक्टर कुंदे से रिक्वेस्ट करूंगा कि वो अपने इस जो आपका एक कीर्ति है, जो आपकी एक्सपर्टनेस है, इसको अपने तक ना रख के थोड़ा सा आगे बढ़ाएं। और जैसा कि मुझे पता चला है कि आपके सेंट्रल गवर्नमेंट में बड़े अच्छे संबंध हैं, निर्मला जी से भी अच्छे संबंध हैं, प्रेसिडेंट महोदया ने आपको बुला के अवार्ड भी दिया है और आपको फैसिलिटेट भी किया है। तो जैसे हमारे यहाँ एक प्रोग्राम चला था पोलियो का, कि हमने एक सेंट्रल गवर्नमेंट की सहायता से पोलियो बिल्कुल खत्म ही कर दिया हिंदुस्तान से। इसी तरह से अब हमारे यहाँ एक प्रोग्राम चल रहा है ट्यूबरक्लोसिस का, उसमें सेंट्रल गवर्नमेंट की बहुत बड़ी हेल्प है और हम लोग काफ़ी उसमें सक्सेस भी पा रहे हैं। स्पेशली जो प्रॉब्लम्स होती हैं रिमोट एरिया में, गांव में, विलेजेस में ज़्यादा होती हैं। अब तो ट्यूबरक्लोसिस उतना नहीं मिलता है शहरों में, लेकिन गांव में भी बहुत है। इसी तरह से जो सबसे बड़ी प्रॉब्लम है स्नेक बाइट की, ये नॉर्मली विलेजर्स को गांव में जाके, जो कि बहुत ही डाउन रोडन है, बहुत ही गरीब किस्म के आदमी हैं, उन लोगों को प्रॉब्लम होती है। और वहाँ जाके प्रॉब्लम होने के साथ साथ उनके घर, मान लीजिए जो ब्रेड विनर है, जो आपको घर में एक घर चला रहा है, जिसके ऊपर अगर उसकी डेथ हो जाती है बिकॉज ऑफ स्नेक बाइट से, तो उससे तो पूरी फैमिली उसकी डाउन हो जाती है, जैसा सर ने कहा। तो मैं रिक्वेस्ट करूंगा सर आपसे कि अगर इसको एक प्रोग्राम बनाया जाए सेंट्रल गवर्नमेंट की तरफ से, और उसमें मैं कहूँगा कि सबसे ज़्यादा जितने भी हमारे PSCs हैं और CSCs हैं, उनके डॉक्टर्स को बुला के ईयरली कोई ट्रेनिंग इस तरह की दी जाए कि अगर स्नेक बाइट आती है तो उसमें क्या करेंगे। और उसके साथ साथ अगर ये टॉक्सिकोलॉजी जो हम लोगों ने यहाँ इतना शुरू किया है प्रोग्राम का, रूपका का इतनी मेहनत लगी है इसमें, अगर उसको भी हम इंक्लूड कर लें कि साल में एक बार विलेज में जो डॉक्टर्स बैठे हैं उनकी ट्रेनिंग हो जाए, तो मैं समझता हूँ उससे काफ़ी हद तक ये समस्या हल हो सकती है। और ये के साथ आपकी कीर्ति भी एक दिनों दिन पहले ही, क्योंकि आप अपना जो ज्ञान है वो एक दूसरे डॉक्टर्स को स्प्रेड करके दे रहे हैं, उनको समझा कर दे रहे हैं, ताकि हमारे गरीब जनते का फायदा हो और हमारे राष्ट्र का उसमें फायदा हो, क्योंकि उससे एक फाइनेंशियल लॉस अल्टीमेटली गोज टू दी सेंटर एक्चुअली। सो इसके साथ साथ मैं यहाँ बैठे सभी लोगों का बहुत बहुत धन्यवाद करता हूँ। और मैं समझता हूँ कि बहुत ज़्यादा टाइम नहीं लेना चाहिए, काफ़ी देर हो गई है आप लोगों की। जय श्री राम, 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 जय श्री राम।
Thank you, sir. May I invite Dr. Dharmawala, today's chief guest, for his words. Dr. Dharmawala is one of the senior most intensivists in our country. He has lots of awards to his credit, the best award that I give to him as his younger brother, he has shaped several institutions on his own shoulders. Tata Main Hospital, Jamshedpur, the current Ultimate Hospital, I have gone there 2-3 times. That hospital, he is instrumental in shaping and saving lots of lives. He was selected for ISCCM Oration in 2012. He has written several books and chapters. Dr. Banambare is regarded as fatherly figure in critical care circles in India. He is very well known throughout the country and abroad. I take a lot of motivation, inspiration, and whatever we have been able to do and launch this program, it would not have been possible. He would not have been around to inspire us. Dr.
Thank you, Dr. Rumta, for your absolute outstanding, flabbergasting speech in favor of me, which I think we will discuss about my acceptance of what you said. Well, I think Dr. Rumta's efforts finally have fruition today. We have been thinking about it for the last 4 years. W4C, a purely non-governmental organization. I do not know whether it can be called a NGO at this point in time, but I suppose in the days to come, it certainly will be recognized as an NGO. No profit, no loss. That's what NGO is all about, I understand. And we have had two very distinct objectives of W4C. One, of course, is the nursing education, critical care nursing education, which still hasn't actually got a shape for certain reasons and for certain good reasons. And I'm sure in the days to come, it will happen. And second is the poisoning. These two aspects have not been so focused by the critical care organizations. We have started in our parent organization, fine, but I think there are many other things that the parent organization of critical care does, which we are a part of it. But these two, I think we have picked up because these are not very well focused by the critical care organizations thus far. It will happen, I'm sure, in the days to come, but we have taken it up with a mission. And that mission is not a small dream. Obviously, we know what obstacles we are going to face in days to come. He talked about 5 steps, and he has very critically considered those almost single-headed. And amount of work that needs to go in, I cannot really think that it is so easy. It is something which only Dr. Rumta can actually spearhead. I see 3 positive points here. When Anuj said that he has declared in 11th of January this as a center of excellence for poisoning, something he would have imagined at that stage, because there were a lot of inputs by then which have gone in. What a onerous and difficult at the same time task it would be to make it a center of excellence. But you have got, Anuj, 3 very important points in favor of this center being declared as a center of excellence. One, of course, is that it's Devabhoomi. which I think repeatedly Dr. Punde has shown and talked about. So it's Devabhumi. It can only happen in Devabhumi. Number two, your hospital is an excellent charitable hospital. You understand what charitable means. Last time when I was here 2 months ago, they said, all of them, and they practice, that any patient who comes to this hospital is never denied. Even if he has to have a MRI, they do not charge anything. You can give anything you like. If you cannot give anything, MRI will be done. So that is the true attribute of a truly charitable hospital. So it's truly a charitable, and the name of course is Swami Vivekanand. It could not have been a better name for the hospital. So it is coming from not only Devabhumi, it is also coming from a truly charitable organization which has already had 14 hospitals, and I think Vrindavan Hospital is very much going to be added to it with a cancer hospital. So it is certainly going to be a chain of hospitals in Devabhumi and also in Uttar Pradesh. Something which will lead the concepts and the objective throughout the country. And of course it is at a height. You know that we are at a height. It is only an organization at a height physically that can actually overview the whole country. And the third I see is you have got a sense amongst us who actually is 100% dedicated and committed to the cause of this particular organization, and that is Dr. Narendra Gupta. Right? Narendra Gupta can do no wrong. He is Indra of the Naras. Narendra, not Indra. And Narendra Gupta can do no wrong. When I see him, every time, last time I came, this time also after 3 months when I come, I see without his knowledge, without his intention, maybe I don't know, he is getting transformed from a human being to an almighty. He has gone to a level which I think all of us would aspire to go to in our pursuit for excellence, in our pursuit for highest achievement that a human being is born with. So that is what all of you know is our salvation. He is already into it. He is actually staying in a place which is an outstanding place. Every time I come, I know there is no possibility of any pollution in the ambience of Dharmawala. Name is also quite infectious. It can never be polluted. And the hospital I see every time, hospital is looking so elegant. Hospitals, the temple is open all throughout 24 hours into 7, I am told. 24 hours a day it is open. Yesterday I came, 7 o'clock I found there is no deity, no priest there. But temple is open, I salute it. It is something which you would see to believe. The ethos that prevails in India. Therefore, these 3 points, I am sure, Anuj has got a tremendous responsibility ahead. But I have got few reservations, Dr. Anuj. Any good thing that we start with a lot of fanfare, a lot of enthusiasm, a lot of celebrations. But as the days go by, we know there are 2 things which actually will be obstacles for our progress. One is, of course, procrastination. I will do it today, or I will do it tomorrow, I will do it day after. That's the greatest enemy of the mankind. I will do it tomorrow, I will do it day after. Number 2, I think is most important is complacency. when we do our pursuit, or we travel in our pursuit for excellence, complacency somewhere always would like to deter us from doing what we want to do. So that is one thing which we have got to be careful about. When we have all these 5 points we talked about, we need to have processes, we need to have infrastructure, we need to also have resources. These 3 things also we have to work it out. Okay? Infrastructure includes physical infrastructure, which we have it here, and accessibility, of course. Accessibility is quite good to Dharmawala. Also the information sharing, generation and sharing of information. This is also a part of the infrastructure also. Information generation, I believe, is that it has got to be an information which is nothing but truth. Which is nothing but truth. We are quite criticized all over that we concoct data. We do not need to concoct data. As we start collecting the information, first year we may have X number of poisonings. Second year we will have X plus Y. Third year we will have X plus Z. And thereon, when we get number of cases increasing, nothing to get disheartened. It is only the first step of information generation and sharing. We say, for example, errors. We take always every month we sit down how many errors. Initially it was 1 or nil. Then subsequently they said 0, 0, 0. I said it can never be. In a critical care setting, every patient on an average has to have 17 errors in a day. You have 10 people in the intensive care unit being treated. You must have at least 170. It's all documented. It starts from 2 to 99. Average is 17. If it is 17, 170, imagine in a month how many? Almost about 500 or more. Or 500, it's more than that. I think 3,000 or it will be. So in that case, we have got to have increase in the numbers of poisonings. Increase in the number is a success. It is not a failure. When we have increase in number, we need to also start putting in our efforts to reduce it. But at the moment, simultaneously, we need to also encourage unearthing the number of poisons. Our outreach to the villages. In one scale, I think Dr. Punde has shown it to all of us today, and we know that also now. In his limited circles, he has been able to actually catch all those poisons. If he has done it, one man, we are so many of us, we should be able to do it for the whole country. I would like to invite all those hospitals all over the country. Please do not put imaginary obstacles, saying that, in government circles we do not do this, we do not share our data, our ethics committee will not allow it. Please, for heaven's sake, do not imagine obstacles and then start working backwards. You imagine obstacles, fine, but get over those obstacles and please share. Not one will share all those. No individual will ever be exposed that he has had this. Only the number which is important. It is only the number, mortality, morbidity that is important. Not who has had complications. So please, for heaven's sake, we would like, you are all ambassadors today, all of you are attending this week. You are all brand ambassadors of this particular cause. Please go out. You need to have parameters in everything. For example, you have, say, putting in a right tube and getting the lavage done. How many cases are getting? What is the percentage of cases where lavage has been done or not done? Not done is our objective. So if it was 190 out of 100 in the beginning, it should come down to ultimately 0. Then only you can have 0 mortality. So all the processes we need to work on and bring those processes to the lowest level of performance efficiency. Means inefficiency, lowest level of performance inefficiency. Then only we can expect that our mortality will become 0. It doesn't happen overnight, it doesn't happen in a month, in a year, in a decade. It may happen years after. But I think we need to embark on this journey for a indefinite period. It's not really something which will get us. Dr. Punde said that, poliomyelitis has been eradicated. But I hear that it's still there. World over, poliomyelitis has been eradicated. But I think in Afghanistan and some part of Africa, it is again surfacing. So if it is so, it hasn't eradicated, right? Smallpox also is similar situation. So therefore, if those are the governmental WHO's help that they have been sort of at it now, and they are again finding that it is surfacing. So this also will be a similar effect. Therefore, we need to all work with a tremendous degree of commitment and no question of any complacency or procrastination. I think we will be able to achieve. Finally, I would like to thank formally Dr. Anuj and his colleagues here who have so voluntarily taken this as a mission, and we may have created history today with this inauguration. And I think years to come, we will see that it blossoms. Like I see all your trees around are having a lot of mango flowers, right? And similarly, this also will blossom, right? I think it is a tremendous day today, and 14th of March will go down in the history of poisoning, zero tolerance mortality for all times to come. India, among all the nations in the world, will stand out and say with pride that we have been able to do it. Thank you very much.
Thank you very much, sir, for your motivating remarks. Dr. Dharmawala reminded me I should invite Dr. Prashant Kumar to say a few words. He is Secretary General of Critical Care Foundation. Dr. Prashant.
Thank you so much, sir. Sabhi namaskar. I can only say that, sir, under your guidance, we all are with you, and I am confident that your guidance will take us towards the goals which you have set. Thank you so much.
Before I invite Dr. Pankaj, Senior Physician here, for vote of thanks, who is also organizing chairman of this program, I have two duties to do. One, I must thank the faculty, one, who have traveled here. Number two, I must mention names, those who have agreed to be part of our team who will participate in chatbot and give 24-hour into 7 duty periodically. So, Dr. Banambare, over and above me, Dr. Prashant. Dr. Prashant, can you stand for me? Please clap for them. Dr. Kunjan, Ludhiana. Dr. Puneet Patiala, Dr. Tejas Ahmedabad. Of course, Dr. Punde, we will trouble you for all poisoning cases.
It will be my pleasure.
Thank you very much. So, we have a team of, we have some other colleagues, Dr. Sai Prasad from Kolhapur, Dr. Venkat from Hyderabad. We have two more colleagues from Rajasthan. We have one Dr. Bharat Jigyasi from Bombay. We have Dr. Vandana and Reshu from Guwahati. One Dr. Giri from, again, Assam. So, the team, I am sure, will multiply in numbers over a period of time. Then we will start looking for our chance rather than, kal phir aa gaya, aaj phir aa gaya, then mera hai. So, may I request Dr. Anuj to felicitate our faculty who may I invite Dhruv? Is Dr. Dhruv Chaudhary there amongst the virtual guests? Dr. Dhruv Chaudhary? I was told that Dr. Dhruv Chaudhary was around. So, may I invite Dr. Kunchan? Dr. Kunchan? Dr. Kunchan, please. Dr. Vivekanand has been contributing whenever we have expected anything from her. She has never ever disappointed us. She has been upfront in making protocols, guidelines, PowerPoint, and a lady at this age, besides her profession, teaching, has household responsibilities. Her husband was very sick during last months. Still, she did everything that we requested to her. Dr. Tejas Prajapati, Ahmedabad. He is a toxicologist of different nature. He deals with industrial poisoning and he is master of doyen of industrial poisoning. Mortality in Bhopal tragedy would not have been that much if Tejas would have been around those times. Dr. Prashant. And finally, Dr. Banamar.
There are Prasad you called. Why Prasad? Prasad is the live wire of Dr. I always tell you that.
मुझे प्रशांत की तारीफ करने में भी दिक्कत होती है सर. Because how can I, क्या बोलूँ इसके लिए? There are no words. He is professor of critical care medicine and I call him too. So he has given me those kinds of rights. Dr. Puneet Singh.
Prasad would like to remain behind the scene.
Dr. Puneet Singh.
The first time I see him coming in front.
Dr. Puneet Singh is associate professor at Patiala. Dr. Shruti Sharma. She is associate professor of clinical care medicine at Ludhiana, DMC.
Nara is a star. I know.
Before I take my seat, Dr. Banambare ko bhi, though he is above all this, but still
It's a tremendous honor, sir. You have been, if he is successful, it is you. So there is no question about it.
Can you make it live? Dr. Dhruv Chaudhary is Professor of Respiratory and Critical Care Medicine at PGIMS Rohtak. He is a great friend and former president of Indian Society of Critical Care Medicine. He also had responsibilities as Dean of PGIMS Rohtak. He is a doyen of academic developments in this country. May I invite Dr. Dhruv Chaudhary to make few comments. Dr. Dhruv Chaudhary.
Can you, Mr. I can see Dr. Sarabdar, I can see Arkin also. Thank you so much, sir. In fact, I want to listen from the side and it's an excellent initiative which was needed and required because today itself we are admitting to the current policy. I think that's the beginning of the hour. We need to create our own protocols, curriculums, and see with our own experiences how the biggest challenge for us is not the management, the biggest challenge is making the right diagnosis. I think that is something what is required and it's with the zero mortality, if I can say so, the time has come for the personal management of poisoning in which we must make the right diagnosis, we must work at the right time. Protocols are needed, but along with identification of critical leader as important because of the unique characteristics of each. So I think as Abhigya will take care of that and certainly with the passion of working along with the team led by you along with Dr. Bharat and very ably supported by Prashant, Kulchan and a lot of other colleagues, we will achieve which was need of the hour. Thank you so much that you have been our own mentors and we look up to you and I'm certain the next generation which is with the Kulchan, with Prashant, RK is also there, I can see heading a department of emergency medicine and everything there. This will take place further and probably the best will be that we can go up to secondary level, that is up to the district hospitals. When we need to have some sort of depending upon the epidemiological, knowing it, what are the areas, which particular poisoning or like the NCPC, what has program on snake and validation. Similarly, rabies, we can work it out with small kids and create our impact on those cities where it requires the most rather than only in the top tier 1 to 2 cities. I mean, that's my wish, and I'm certain we will be there to provide mentorship and leadership, and a lot of our colleagues who are excelling in it will take to that level. Not staying in the medical college or corporate, but going up to the district hospital for early diagnosis and management. Thank you so much, sir.
Thank you, Dr. Dhruv Chaudhary. Utterly fair in my duties, I would not have thanked Messrs. Asupon, the software company of Mr. Saksham, who constructed the software in about 3 months short time. I have experienced that software construction takes 6 months to 1 year. It's anybody's guess. And he has done it, and he has done it successfully. It is very simple, and we have already started entering our data. Thank you so much, Saksham. And I invite Dr. Pankaj to present a vote of thanks.
Thank you so much, sir. Sabhi ko Ram Ram. I am Dr. Pankaj on the behalf of our national committee. Respected chief guests, esteemed faculty members, esteemed guests and participants, and my colleagues. On the behalf of the organizing committee, I extend my heartfelt thanks to all our respected faculty for sharing their valuable knowledge, experience, and clinical expertise during this toxicology certification clinical workshop. Your guidance has made this workshop truly enriching and meaningful for all of us. I sincerely thank all the participants, delegates for your enthusiastic involvement and active participation, which have greatly contributed to the success of this program. I would like to offer a very special thanks to our mentor, Dr. Narendra Runka sir, for his inspiration, mentorship, and constant encouragement to all of us to do new things each and every day. I also express my sincere gratitude for overall guidance and support of our Dr. Anush sir and Tara ma'am, whose direction has been invaluable in making this workshop possible. My gratitude also goes to the management of Swami Vivekanand Charitable Hospital, Dharmawala, and to the entire organizing team, volunteers, and support staff for their dedicated efforts behind the scene. Without them, we will not be able to do this function. Once again, I thank you all for making this workshop a great success. Thank you.
I wish we have 3 years for Dr. Vaibhav Mahesh. He has been doing all the work behind the curtains. He never came in the forefront, and during last 2-3 weeks, he has been working day and night to make it success. Thank you, Dr. Mahesh. So, we have the national anthem, Vande Mataram. We stand for